We are live.
Good morning. Welcome to GuruSangam, which is an AIOS initiative. This is an initiative specifically for teachers to identify the best of teaching resources in the country and encourage them to do even better and utilize their services as national resources for elevating teaching resources in the country. The aim of GuruSangam is to educate, elevate, and finally excel. This was the AIOS presidential initiative, and the president of AIOS currently is Dr. Harbans Lal. The session will be moderated by Dr. Gunjan Saluja, who is a trained oculoplasty surgeon from API Center for Ophthalmic Sciences, AIMS, Delhi, and currently heads Bhartiya Advanced Eye Center in Bhilai. And Deepak Mishra, who is the member of Academic and Research Committee and also an associate professor at Regional Institute of Ophthalmology, BHU, Varanasi. Dr. Deepak has a specific interest in oculoplasty, and that's why he is here, apart from being an excellent comprehensive ophthalmologist. So I hand you over to Dr. Gunjan Saluja and Deepak Mishra for further proceedings. The first speaker is Dr. Pushpa Kumari, and Dr. Gunjan will introduce.
Thank you, sir.
Very good morning, everyone. So our first speaker today morning is Dr. Pushpa Kumari, ma'am. She is Additional Chief Medical Officer at Ispat General Hospital, Raulkela, Odisha. Ma'am has done her MS from Behrampur Medical College, followed by her FECO training and short fellowship in oculoplasty. Till now, she has guided 10 DNB students as a guide and co-guide for their thesis. She is a regular DNB examiner and invigilator. Ma'am will be talking about Ptosis evaluation. Over to you, ma'am.
I can share the screen?
Yeah.
Yes, ma'am.
So my slide is visible?
Yes, ma'am.
So first of all, good morning and happy new year to everyone. I must congratulate the team GuruSangam, who has constituted a very good platform to give opportunity for our teachers, and I am very happy to get this topic which is very close to my heart, that is evaluation of ptosis in front of 3 oculoplasty surgeons like Santosh Sunawar. It is very difficult to speak, but if any mistake is done, you may excuse me. Thank you. So there is no financial. I acknowledge my DNB and my patients. So what is ptosis? It is drooping of upper lid more than the normal. Usually lid covers the upper 1/6 of the cornea. Then must we know what is the inverse or reverse ptosis? So when lower lid moves upward from this normal position from lower limbus. So while going for the evaluation, we must know what is the muscles which involved in the movement of the lid and also some bit applied anatomy. There are 2 more muscles. One is protractor and other is retractor. Retractor means which cause elevation of the lid. There are 3 muscles: levator palpebrosuperior, which elevates 15 to 18 mm, then molar muscles, then frontalis muscle. And protractors are orbiculis oculi. My slide is filled.
You can click on the screen, it will start moving. It's moving.
Okay. So why to know ptosis? Besides cosmetic concern and psychosocial impact, it has a great impact due to ocular and visual defect which lead to significant morbidity. And though it is most common, but it is often underreported. And at times it may reveal fatal, life-threatening emergency like due to people involving third nerve, due to posterior aneurysm. So we must evaluate ptosis in a proper way. So goal of evaluation is to know what is the type of ptosis, what is the degree or severity of the ptosis, whether it is simple or associated with any complicating factors, or based on the LPS action, we can decide what is our plan of surgery and also what is expected outcome. So proper evaluation of ptosis is very important. Before going for evaluation of the ptosis, we must know what is pseudoptosis. Pseudo means which mimic like ptosis. It is a mimicker. So the cause may be in same eye or contralateral eye. In same eye due to loss of support of the underlying globe like microphthalmus, enophthalmus, enophthalmus, or due to dermatochalasis. If there is a superior sulcus deformity or the growth position is below, like hypotropia, yeah, broad ptosis and less ptosis, it can give rise to pseudotosis. Whereas in the contralateral eye, if there is a presence of lid retraction, it may be true or false, or proptosis, facial palsy, high myopia, congenital glaucoma. This condition must be excluded before going for examination for the ptosis. So these are the few pictures. Here on the left side, it is a macrophthalmos of the right eye, whereas in the right side, it is the enophthalmos of the left eye due to orbital floor fracture leading to prolapse of the structure. Lead retraction, how to exclude? There is a true lead retraction or pseudo lead retraction. As we see in this figure, there is a pseudo retraction. When we occlude the ptotic eye, there will be elevation of the lid or by line print test. And there, whereas in the right side, there is a lid retraction. Again, in case of dermatochalasis, while elevating the ptosis, there is a correction of the elevating the lid skin. There is a correction of the ptosis. Similarly, this is the left eye proptosis and superior sulcus deformity. So, step-wise ptosis evaluation, these are the things, history, as usual in all cases. If you take proper history, then your 50% work is done. Then inspection, ocular examination, ptosis measurement, ancillary test, and decision making. And photographic documentation is very, very important in all oculoplasty cases to avoid any medical legal complication. And out of all this, ptosis measurement is most important. So I will deal in detail subsequently. In history, we should take onset, duration, and progression. That is ODP. Among the onset, it is maybe acute, subacute, or chronic. In acute, in unilateral cases, it is most likely due to neurological or any inflammatory cause like myositis. Whereas in chronic, it is most common cause is involutional ptosis. Whereas in bilateral cases, again, it is due to tumor or inflammation of the brain or chronic progressive external ophthalmopathy. Whereas in case of chronic, it is due to myogenic, involution, or inflammatory. Family album or family album tomography, that is otherwise known as FAT, is important to know whether the presence of ptosis is congenital or acquired, or it is static or progressive. So it will give you some sense, because patient may forget his history, may not able to give the proper history. So we have to go for family photo album. What are the causes of the variable ptosis? So myasthenia gravis, synkinesis, or aberrant regeneration of the third nerve, and at times some in normal person with having excellent LPS section, they can voluntarily control their ptosis. Family history regarding, we have to ask for the old photograph, whether there is a presence of congenital ptosis in their family or blepharophimosis syndrome or any myopathy. If there is a presence of ptosis, then what type of correction was helpful? Then drug history, use of systemic and topical steroid drug, opiate drug like morphine, heroin, use of kajal or mascara which can cause epileptic type of ptosis. Then while taking all this history and greeting the patient, we can simultaneously handshake with the patient and know whether it is good grip or unable to release the grip or loose grip. Then we can suspect the presence of myotonic dystrophy. History of trauma or surgery like cataract surgery or glaucoma surgery, where we have taken the superior rectus suture, bridal suture, but now we are not taking superior rectus bridal suture. Cardiac disorder, it will show whether there is association of the systemic association or for anesthetic purpose. Thyroid disorder, dysphagia, change of voice, use of hard contact lens, history of allergy like VKC, it will indicate due to continuous rubbing, it may cause the dehiscence or aponeurotic ptosis. History of drug allergy, use of anticoagulant and blood thinner is important for management purpose. Before going for evaluation of the ptosis, we must some working knowledge of the type of ptosis. There are basically two types of ptosis, congenital and acquired. In congenital, it is simple or complicated. When it is associated with the monocular elevation deviation or blepharophimosis syndrome, or there is Marcus Gunn-Jaubaki, then it is known as complicated. Whereas in acquired ptosis, it is myogenic, neurologic, aponeurotic, and mechanical. I will deal all in subsequently slide. First comes under inspection, whether we have to see whether it is unilateral or bilateral. Then head posture. Head posture, what do you mean by the head posture? It includes three things: head tilt, face turn, chin elevation or depression. Usually in case of congenital ptosis or bilateral ptosis, to avoid clear the visual axis, the person adopt head tilt backward and chin elevation position. In ocular posture, we have to see whether it is orthophoric or hypertrophy, because in case of hypertrophy, upper lid will follow it. So it is a case of pseudotosis. For facial symmetry, we have to see whether there is a frontal wrinkle is present or facial dysmorphism, or in case of blepharophimosis syndrome. In eyelid, we have to see whether there is a presence of any scar, mass, dermatochalasis, blepharochalasis, change in lid position with the jaw movement or eye movement, then to whether there is a presence of frontalis overaction is present or not, then position of the eyebrow and eyelashes, then periocular inflammation, enophthalmos and proptosis to exclude the pseudotosis. After inspection, we will go for examination of the visual acuity, uncorrected, best corrected, to exclude any amblyopia in case of congenital ptosis or in acquired ptosis. Then color vision to exclude the second nerve function, and slit lamp examination of extraocular movement. So here we will examine in 9 directions. So here the ocular movement is normal. If ocular movement is not normal, we can suggest it is a third nerve involvement. But here it is normal. Then examination of the orbiculus oculi. So there are two signs: eye peak sign and eyelash sign. So what do you mean by the eye peak sign? The lid drift open slowly after closure and the sclera is visible due to fatigue. So it is found in case of myasthenia gravis due to weakness of the muscle. Then what is eyelash sign? Lash cannot be buried by forcible lid closure. So we have to examine the orbiculus oculi also. Pupil examination plays a vital role. Whereas if it is normal size, it may be due to pupil non-involving third nerve palsy, or when pupil is dilated, it is pupil involving third nerve palsy. Whereas in case of Horner syndrome, it is due to meiosis. We have to search for the rapid relative apparent pupillary defect to exclude the second nerve involvement. Dilated function, all the examinations are done in undilated people, all measurements are done in undilated people, but dilated fundus examination is done lastly to exclude any pigmentary retinopathy, which are the association of the chronic progressive myopathy, as in Kern-Sierre syndrome. Ptosis measurement plays a vital role. We should not hesitate to measure it repeatedly if you have any doubt. This includes vertical peripheral height, margin reflex distance, that is MRD 1, 2, and 3, LPS section, margin crease distance, margin limbal distance, pre-tarsal show, and vertical tarsal height. Vertical peripheral height is measured in primary gaze, up gaze, and down gaze. Usually in male it is 7 to 8 mm, in female it is slightly more, that is 9 to 10 mm. Then this is the vertical peripheral height in congenital ptosis. As we know, in congenital ptosis, the vertical peripheral fissure in down gaze is more than normal case. Whereas in up gaze, again, ptosis is accentuated. It is due to failure to contract and failure to relax the LPS. So what are the causes where vertical peripheral height in up gaze is increased and decreased? It is increased in Lambert-Eaton myasthenia, Graves' ophthalmopathy, hyper or hypokalemia, and acquired aberrant regeneration, whereas it is decreased in case of inflammation or adhesion of the superior rectus or levator palpebrae superioris, whereas vertical peripheral height is decreased in down gaze in case of involution ptosis and aponeurotic type of the congenital ptosis. So we must not forget to this. Suppose we think there is no increase in the palpebral fissure in down gaze, it is not a congenital ptosis. It may be due to aponeurotic congenital ptosis. Whereas it is increased in congenital ptosis, trauma or tumor in superior orbit, aberrant regeneration, or any inflammation or myocytosis of the muscle. Grading of ptosis is by vertical peripheral height by difference in the between two height. It is mild if it is 2 mm, moderate if it is 3 mm, severe it is 4 or more. Horizontal palpebral fissures length is also important to exclude phimosis, telecanthus, hypertelorism. Margin reflex distance, it includes MRD 1, 2, and 3. 3 is of historical importance, but we must know as a student because some old examiner may ask you what is MRD 3. So margin reflex distance, how to measure? It is a distance from central pupillary light reflex to upper eyelid margin with eye in primary position. While going for measurement, first do this in a well-lit room and direct light should not be fall there and you have to light diffuse light, not bright light to avoid any blepharospasm or photophobia. Normally, it is 4 to 5 mm. Then how to know the severity of the ptosis? By the amount of the difference between the two eyes. If it is unilateral ptosis, if it is bilateral ptosis, then we have to subtract from the normal, that is 4 to 5 mm. As we see here in B, it is a mild ptosis, C, it is a moderate, and D, it is a severe ptosis. What is MRD2? This is the distance of corneal light reflex to the center of the lower eyelid in primary gaze. Normally, our lower lid position is, it just touches the, just clear the lower limbus. But here not, the distance of MRD2 is not fixed, depending on the position of the lower lid. Normally, 5 to 5.5. Ptosis, then by adding MRD1 and MRD2, it will give the palpebral fissure height. Normally, the ptosis measurement by MRD1 or vertical palpebral height should coincide. If it doesn't match, then you suspect there is any discontinuity or variability of the MRD2. MRD3, it is distance in millimeter from corneal reflex to upper lid margin in extreme up gaze. It indicates the action of LPS. What is MLD? That is margin limbal distance. It is measured from 6 o'clock position to lid level in extreme up gaze. Suppose in some cases hypotropia or hypertropia, patient is associated with the squint. In that case, MLD is important. MLD indicates LPS section by Puterman's method and amount of resection of the LPS muscle needed in for correction. It is correction by the difference in MLD between 2i into 3 mm will give the amount of resection of the LPS. Then what is margin fold height? It is essential for to know the symmetry between the both eye postoperatively so that cosmesis will be maintained. Margin crease distance, it is measured in down gaze, measured in down from the lid margin to most prominent fold. If not visible, just slightly raise the lid margin to see. And if we see multiple, then you have to measure the most prominent crease. Normal in male it is 7 to 9 mm, in female it is 9 to 11 mm. If it is absent or faint, it will indicate it is a case of congenital ptosis. If it is very high, then it is a case of involutional ptosis. If there is a multiple ill-defined, then it will indicate dehiscence of the LPS. Margin crease distance and margin lid fold. So what is the basic difference between two? In margin crease distance, we measure it is in down gaze, whereas in margin lid fold, we measure in primary gaze, as in A and B photograph. Pre-tarsal show and what is tarsal plate show and what is brow fat span. It is not so, it is span. It is the distance between the lid margin and skin fold with the eye in the primary position. What is the need of tarsal plate show and brow fat show? When ptosis is associated with the fat prolapse or excessive lid skin, then for blepharoplasty, we need this measurement. Otherwise, it is not required. LPS section is the most important measurement. It determines the type of ptosis and its treatment. So there are three methods to know the LPS section. One is Burki's method, where excursion of the lid from down gaze to up gaze is measured. Puterman's method, that is by MLD, that is margin limbal distance, and ellipse method in case of children or uncooperative patient. So this is the video. We ask the patient to look down, extreme down gaze, then by negating the action of the frontalis, so we have to push the just our thumb over the eyebrow, not above or below, not too hard, not too loose, to negate the function of the frontalis, and that the extension of the lid will in millimeter will give the LPS action. This photograph is taken from the one book where they have applied pressure just above the eyebrow. So it is not a correct method, it is a wrong method. Uterman method is, already I have told that it is margin limbal distress from the 6 o'clock to the extreme up gaze. Ellipse method. So how to perform ellipse method? Just invert the lid, ask the patient to look in down gaze, invert the lid, and ask the person to look upward. If lid immediately returns to normal position without lid, then
अभी आ रहे होंगे 2
good
मिनट में
function.
यही होंगे वो।
कहीं
LPS
आसपास ही गए हैं, बोले चेकआउट कर गए हैं, इसका
whether
मतलब वो
it
आ
is
रहे
a true, fair, good or excellent. If it is less than or equal to 4 mm, it is poor, 5 to 7 fair, 8 to 12 is good, and more. This is by Burki's method. Bell's phenomena is very important to whether you will conduct ptosis surgery or not. If Bell's phenomena is absent, it is a contradiction for ptosis surgery. So how it is tested? Tested by asking the patient to close the eye while examiner attempt to open. Eye moves normally upward and outward. What is inverse? When it is up and in. What is reverse? When it is down and out. What is perverse? Any direction. So how to grade Bell's phenomena? If more than 2/3 of the cornea disappear, then it is good. If 1/3 to 2/3 of cornea disappear, it is fair. If less than 1/3 of cornea, then it is poor. So this is the video of how to check the Bell's phenomena. So just look down and gently elevate the person. Here it is normal Bell's phenomena with good Bell's phenomena. What are the special tests which will indicate whether there will be post-operative complication like exposure keratopathy or corneal complication? For that, we have to check corneal sensation, leg of thalamus, Bell's phenomena, whether there is a normal blink reflex is present or not. Then Surmer test, tear film breakup, all the workup of the dry, like tear meniscus height, so that we have to exclude whether there is a presence of dry eye is there or not. Here, this is video of the corneal sensation. We have to see how to perform the corneal sensation by taking a wisp of cotton. We have not to occlude the visual axis. We have to stand just beside the patient and quadrant by quadrant we have to check. Then this is the leg of thalamus. So incomplete closure of the eye due to facial palsy. This is the TBO2 tear breakup time and Surmer test. What are the special tests? Beside this test, we have to do this test if it is indicated, like phenylephrine test, fatigue, sleep, ice pack, tensilon, dry eye avulsion, corneal. Imaging is not important in every case. Suppose we think it is a people involving third nerve, then only we can go for imaging. Otherwise, it is not in the. Also, in case of trauma, to exclude orbital floor fracture or other cause. Single nerve fiber is important for the myasthenia gravis. So, what is phenylephrine test? After there is already, as usual, while we are putting the drop, we used to put it inferior cul-de-sac, but in case of phenylephrine test, we have to put the drop in superior cul-de-sac, and after putting 2 drops, we have to see the effect of the phenylephrine after 5, 10 minutes and 30 minutes. If it is not occurring after 30 minutes, then you flag that it is test is negative. If it is positive, there will be rise in MRD by 1.5 mm or greater. It indicates that molar muscle is viable, so operation to resect molar muscle is and conjunctiva can relieve ptosis. If it is negative, we can go for Fasanella cervid operation. This is the ice pack test. After applying ice pack for 2 minutes, we will see whether there is any improvement in ptosis or by measuring the MRD1. Sleep test. Again, we suggest the patient to sleep or give rest in clinic for 30 minutes. If there is any improvement, it will indicate myasthenia gravis. Similarly, in fatigue test, it can done by both method. First, we ask the patient to look forward, then look up for the 20 seconds. If there is a gradual drooping of the lid, it will indicate it is a fatigable ptosis and indicate myasthenia gravis. Tensilon test is not done regularly. Whenever there is any doubt, and then we can perform tensilon test in OT setting with proper precaution. First, we inject 2 mg IV and check for any side effect. If there is no side effect, then only we can inject whole 8 mg. Here, this is a before injection and after injection, so there is improvement. If there is an improvement in the ptosis, then you think that it is a myasthenia gravis. I will cover some salient features of acquired ptosis, like in epinotic ptosis examination finding only. If there is a high lid crease or absent lid crease, good levator function and deep sulcus, then think of it is a epinotic ptosis. Then again in epinotic ptosis, there are 3 terms. One is disinsertion, dehiscence and degeneration. So what are the clinical features of disinsertion? I will take one by one. In case of disinsertion, the eyelid crease will be very high, ptosis in down gaze will be worsened, and LP section is good to excellent, but iris show or underlying cornea will be visible due to absence of the aponeurysm of the LPSS, and here type of surgery is reattachment or reinsertion. Whereas in case of dehiscence, the eyelid crease will be normal or high, ptosis in down gaze will be stable, and LPS section is good to excellent, and underlying iris is not visible. And here treatment is plication. What do you mean by dehiscence? So it is stretching of the aponeurosis due to constant rubbing or any mascara use or due to any old age. Whereas degeneration is due to fatty infiltration of the LPS muscle. So here eyelid crease will be normal. The ptosis in down gaze may be stable or there will be lid lag. LPS section is moderate to good. Underlying eyeball or iris is not visible. Here type of surgery is resection of the LPS because muscle is not able to contract. So we have to accentuate the function, we have to resect the LPS. Mechanical ptosis. What do you mean by mechanical ptosis? When there is any excessive weight on the upper lid or due to lid scarring like tumor, multiple chalagia, lid edema, dermatoclasis. So here we have to treat the underlying cause. In third nerve palsy, along with the ptosis, there will be ocular, there will be eye movement restricted. So we have to see whether there is any normal abduction, defective elevation, defective depression, and at the same time, pupil examination is very important. I have given in a tabulated form to know in a once glance to how to differentiate because there are certain things like lid crease margin. It will indicate in congenital or aponeurotic ptosis. Similarly, LPS section, it is reduced in congenital and also in there is dysgenesis cases. The examination of people is very important. It will be dilated in case of people involving third nerve palsy, meiosis in case of Horner syndrome. And one thing you must remember that in case of myogenic, people is always spared. So examination of people is very, very important. Then other features will corroborate our diagnosis. What is Marcus Gunn jaw winking phenomena? Retraction of the ptotic lid in conjunction with stimulation of the ipsilateral pterygoid muscle by chewing, sucking, or opening the mouth or contralateral jaw movement lead to improvement in the ptosis. So how to grade the ptosis? There are two methods. One is objective, other is subjective. In objective, we will take the measurement. If it is less than 2, it is mild, 2 to 5 moderate, more than 5 is severe type of Marcus Gunn. Subjectively, how to measure by the position of the lid over the limbus. If it remains in non-ptotic position, that is 1.5 to 2 mm below the limbus, upper limbus, then it is mild. Up to superior limbus, it is moderate. Beyond superior limbus, with scleral, so it is severe. Depending on this grade, our type of surgery depends. So we have to grade properly. Then other types we must know. We only know Marcus Gunn jaw winking. There is other phenomena, that is inverse Marcus jaw winking phenomena, and other is Marin-Amart syndrome. In inverse Marcus Gunn jaw, opening of mouth causes drooping of lid. Here, again misfiring between the third and fifth nerve in opposite way. And whereas in case of Marin-Amart syndrome, it is due to misconnection between the third and seventh nerve. Here it causes smiling or opening may cause closure of eye due to blepharospasm, and here treatment is botulinum toxin. Whereas in case of Marcus Gunn and inverse Marcus Gunn, we have to go for bilateral sling with extirpation or removal of the LPS muscle total. Otherwise, there will be no correction. Before going for any surgery, if we don't do hearing test, our examination is incomplete. Why it is important? Because we have to see, otherwise you did operation and post-operatively there will be drooping of the other lid. So it will create medico-legal problem. So first test, elevate the ptotic eye and observe the position of the another lid. As we are seeing in this figure here, left eye ptosis. Left eye ptosis, after elevating the left eye, there is a ptosis of the right eye. So if there is a fall or more than or equal to 1 mm, then test is positive. Positive test indicate for bilateral ptosis surgery. Even if it is negative, we have to counsel the patient for chance of ptosis of the another eye post-operatively. So we can save our skin. This is the ptosis examination chart. We must mug up this chart, and often all student, PG student have a phobia if they take even how to go for measurement. It usually takes only 3 to 4 minutes. If you do practice every day, then it is very easy case. So these are the ptosis examination chart you have to do according to our measurement. Then how to write the final diagnosis? We have to mention unilateral or bilateral, congenital or acquired, simple or complicated by any factor, and what is the LPS action, whether it is poor, mild, fair, or excellent or good, whether it is acute onset or chronic, progressive or non-progressive, it is isolated or systemic association. As for example, I have written here simple, moderate, congenital ptosis with poor LPS and with good Bell's phenomena. So there are certain mnemonics as seen by some madam. It is bad. Bad means Bell's poor, anesthetic cornea, dry eye. And this is the destiny for the examination mnemonics. And one more is examination of the lid is by AP ophthalmology. So to conclude, thorough assessment is very, very crucial. And thorough assessment and thorough history is a crucial key point. Levator function is a deciding factor for choice of surgery. So you don't hesitate to measure the levator function if you are in doubt. Again, go for measurement. And customize the surgical solution because there is no rule of thumb. You will cut this amount of muscle, this one. So you have to customize according to case. Counseling, never raise the expectation too high. Always under promise and over deliver. And photographic documentation of every case is must to avoid medical legal complication. Thank you very much.
Hello.
माधोपुर की तरफ घूमोगे वैसे ही वो
Thank you, ma'am, for the wonderful talk. And
Thank you.
almost it's just like an encyclopedia of the whole topic. I
Yes,
think nothing is left for
एकदम
the
रोड पर
I have
discussion,
not
but
left
still,
anything. Actually,
I
I
would
have
like
followed
to.
Santosh Sonawar's all video. 3 times. He is my guide.
No, ma'am. The way you shown each and every point with like eyes test and different test with own photographs and the things,
I
it's
felt them.
really,
Yeah.
it's really wonderful.
Okay, thank you.
Any comment from the expert panel? Dr. Chandra, ma'am, yours view on ma'am.
No,
Topic.
it's true for me also because she has almost completed the total topic. No stones are left.
So we can invite next one, and if any question is there on any social media or anywhere, then we can ask you at the end, ma'am.
Okay.
So I just want to add one point, which is I
Yes.
think very important is, see, myasthenia we usually expect it to be present in middle-aged females or middle-aged persons, but nowadays a very disturbing phenomenon which is seen is that even children, they can present with myasthenia. You can just have subtle signs like lid twitch sign. And as ma'am has very nicely highlighted that
I
you need
forget
to
Akoven.
the extraocular movements in every case. So that is important because sometimes they might also have limitation of extraocular movements, and sometimes even if limitation is not there, just a simple lid twitch, looking at that is called Cogan's lid twitch sign, that can be seen easily and documented very well. IcePack test, as you have very well highlighted, is a very simple bedside test that can be performed. Similarly, one more thing about aponeurotic ptosis is that definitely the marginal reflex distance, it is not going to correspond with your LPS action. So your LPS action will be good, but you can see that the patient will have good amount of ptosis, severe ptosis, but the LPS action would be good in those cases. So I think, and yes, another important thing is you should always evert the lid also and see.
Yes.
Because VKC, we have told, sometimes can cause mechanical ptosis also and can be a cause of aponeurotic ptosis as well. So I think ma'am has covered everything, and we can move on to, if there are no comments, We can move on to our next speaker.
सारा सारा सब ज्यादा पैसा वाले हैं ये तो
Please
Yeah, so I'll quickly
share.
share the screen. Wait a minute.
आप वो डाउनलोड किए जी
अरे एक मिनट रुक जाइए.
यात्रा
Yes.
Yeah. Our next speaker is Dr. Chandra Chakravarti ma'am. She is the associate professor at RIO Kolkata. She is very active member in the WAS and all the PG activities in the West Bengal. She has conducted several PG programs there. She has published more than 65 international and national publications. Also written a book on the Viva and the OSCE for the practical examinations. Ma'am is going to teach us about the approach to a case of proptosis. Ma'am, please. Chanda ma'am?
Hi, yes. Yes. Am I visible? Visible
Yes,
and
ma'am.
audible?
Yes. Yes.
Yes.
Visible and audible.
You-
Uh,
Both slide and you both.
Thank you, Deepak. And both Gunjan Saluja,
Gunjan,
our
Dr. Gunjan.
moderators, Dr. Gunjan. And a very good morning to all our panelists, speakers, and the most important person behind this great project and great show is the President, Dr. Harbansh Lal, and our very own Santosh Anohar sir, who is always active in all these academic activities. So without much ado, I want to start my topic. It's the case of approach to a case of proptosis. It's a vast topic. Just the overview of the topic, I will be talking a bit of relevant anatomy, terminologies, the classification of proptosis, work of how to do approach a case of proptosis, the management, a bit of it, and if time permits, I'll show you some cases. Coming to the a bit of anatomy, as I told, the orbit, these are two pear-shaped structures in front of the cranium. They are very strategically placed. They have so that the eyeball within them are protected from all the outside trauma and injury. 7 bones which come in formation of these orbits are the frontal bone, then sphenoid, zygomatic, maxilla, palatine, lacrimal, and the ethmoid bone. Among these 7 bones, the medial wall is formed by the 4 bones. Medial wall is important because this is traversed by multiple foraminas, and this is very thin also because of the presence of the lamina papyracea of the ethmoid. And superiorly, the roof is also important because the steady subperiosteal, as the bony orbit is covered by an periosteum. The subperiosteal space is more spacious in case of the roof and the medial wall of the orbit. So you can see the orbital subperiosteal hematoma on collection of the fluid or any, as because this is traversed by multiple emissary veins, these 2 walls. Within this orbit, the orbit is a 30 ml volume structure. Within the orbit situated the eyeball. The eyeball is only 7 cc, and rest of the orbit is covered by the structures like muscles, vessels, nerves, then a fat, and the lacrimal gland superotemporally. And as I told, the multiple vessels and nerves are passed through these. One, there is a fissure in the superiorly, that is in the roof, so that is the superior orbital fissure, inferior orbital fissure at the floor, and there are some, and one most important thing at the orbital apex is the optic canal. So these are important fissures and foraminas which are traversed by multiple important vessels and nerves, which takes place our activities of the eyes, and which are important if there is a lesion in the orbit, so that we can judge the function of these structures and can narrow down our diagnosis. So before talking about proptosis, just a few terminologies I want to acquaint you. One is the proptosis, dystopia, displacement, hypertelorism, exorbitism, and pseudoproptosis. Coming to proptosis, abnormal protrusion of the globe, as you can see from the protrusion of the globe from the lateral orbital rim due to a space occupying lesion in the orbit. That is we call proptosis. The absolute measurement, I will come to the measurement later also, how to take measurement and all. Absolute measurement is 20, more than 20 millimeter, and relative is more than 2 millimeter between the two eyes. There are mild, moderate, and severe. Mild proptosis we will call when it is 21 to 23 millimeter. Moderate is 24 to 27 millimeter, and severe is more than 20 millimeter. Then we call it a severe proptosis. Then if the globe is bulged forward, there is a proptosis. Along with that, it is pushed sideways. That is displacement of the globe sideways. Then we call it displacement either in the coronal plane or in the sagittal plane. Like as you can see, in this picture, there is a mass in the ethmoid which is pushing the globe laterally. And in the next picture, this one, you can see there is a mass which has been pushed, which pushed the globe inferiorly. So in this way, we can come to diagnosis in which part of the orbit the lesion is situated. Then what is dystopia? This is also a very commonly used term. Globe is displaced in the coronal plane due to lack of support. Like if there is an fracture in the orbit so that quite a lump sum volume has gone down. So in that case, the globe will be, there will be enophthalmos, and the globe is in the coronal plane, it has displaced downwards. Few more terminologies like hypertelorism, increased in the interpupillary distance or the bony interorbital distance, we call it hypertelorism. Telecanthus is increased intercanthal distance. Why this is important? Because if a patient has got congenitally this problem, then we are not worried about it. But suppose the patient has developed this problem later on, the hypertelorism or telecanthus, then we have to take it with a pinch of salt, and we have to look for the diagnosis and what is the thing underlying behind this. Another thing, exorbitism. This is we also call commonly proptosis, but actually nothing is pushing the globe or there is no mass lesion. The thing is that there is shallow orbit, which is seen in case of craniosynostosis, like in Crouzon's disease, in Apert syndrome, like this. The most important is the pseudoproptosis. Many times our postgraduate students, they are confused that whether it is at all a proptosis or a pseudoproptosis. There are conditions like in high myopia, pathological myopia, especially when one eye is a high myopic, other eye is normal, then you can have it. Then bucthalmos, another condition, the pseudoproptosis, contralateral enophthalmos, then one eye ptosis, all this, and facial asymmetry can give rise to this picture of pseudoproptosis. We have to be very careful about this. Now coming to my topic, classification of proptosis is very important before going to examine a case. How we classify proptosis, it can be various classifications are there. One is etiologically you can classify by depending upon laterality, direction of proptosis, onset, duration, and progression. So if we look at this etiological proptosis, it could be inflammatory, vascular, neoplastic, and miscellaneous. In the inflammatory group, we have two varieties. One is infective, one is non-infective. And again, in the non-infective variety, we have two group of diseases. One is a specific non-infective condition, inflammatory, and another is non-specific condition, which we are more, we come across this non-specific more frequently. But nowadays, actually, these non-specific things are becoming less and less because we are diagnosing it as a specific more and more. Coming to the infective variety, this is very commonly we see all these conditions like orbital cellulitis or orbital abscess, like in this case. And another thing is that this parasitic disease, Either it is in this picture, you can see a myocystic sarcosis in the this type of patient can present as a case of orbital cellulitis something, or it could be because of the fungal infection like a mucormycosis. So that is also same. So coming to the next group, few example of this non-specific variety of orbital inflammation. Like in this, we have two groups. One is the diffuse and one is the localized variety. In the localized variety, these are either it could be anterior inflammation, or it could be posterior, or it could involve the muscles. We call it myositis. This myositis may involve a single muscle, or it can involve multiple muscles, or it can involve bilateral also, or it can involve only the apex, that is orbital apex is involved. In that case, there'll be apical variety will involve your optic nerve, and RAPD also you will get. In perineuritis also only or it may be a combination of all this together, anterior, posterior, myositis, dactylitis, everything is together. That also is seen. So this is commonly, we know that this is a pseudotumor, but now this pseudotumor, we have omitted this abbreviation. We don't call it nowadays pseudotumor, we call it an AIOS, idiopathic orbital inflammatory syndrome. Coming to the specific inflammatory variety, this is also not very less. As I told, this number is actually increasing as we are doing more and more lab investigations and all. This is one example of this granulomatosis with polyangiitis. This is one of my patients, a young lady of 40 years, a known case of Wegener's granulomatosis, the other name of this. As you can see, the MRI is showing almost the diffuse involvement, especially the muscles. The patient came to me with this picture along with dimness of the vision, and the extraocular motility is involved. This is another new thing which has come up just for a decade only. What is this? This is an IgG4 orbitopathy. This patient came to us with a one-eye orbital cellulitis picture. In the next year, the patient presented with again another eye involvement. So this is again, this IgG orbitopathy can involve a generalized systemic disease, or it can involve only the orbit also. This TED, this is the most common cause of orbital. This is, I will say, this is commonly known as exophthalmos actually, not proptosis. We call it exophthalma. The TED, endocrinal proptosis. This is all of us. We are very acquainted with the picture of TED. The patient will coming to the vascular variety, the capillary hemangioma, the cavernous hemangioma, more common in adult female, arteriovenous malformation, orbital venolymphatic malformation, commonly known as lymphangioma, or caroticocavernous fistula also. This is another variety. Most important, I think, neoplastic variety. Neoplasia may be benign or malignant, as we all know. In the neoplastic variety, we can have cyst like a dermoid, or a mucocele with a model mucocele in this picture, or a frontal mucocele can cause proptosis. A glioma, axial growth proptosis is produces. Pleomorphic adenoma, though it is a very large size, but it is a benign condition. Then the malignant condition, the primary, secondary, and metastatic. And the primary variety within the orbit, the rhabdomyosarcoma. Secondary, that is, it is coming from the acute lymphatic leukemia or other blood disc acute myeloid leukemia, which produces granulocytic sarcoma. Then metastatic variety, the metastasis can come from either from the breast in case of female, or in case of male, it can come from the lung or the prostate. the last one, not the least, the trauma. The patient can come with a subperiosteal hematoma. As you can see, a boat-shaped hyperdense shadow, hyperintense shadow here, lesion, that is a subperiosteal hematoma. Or the patient can give an history of foreign body long time back, and the foreign body granuloma has pushed the globe outwards. Or orbitopalpebral emphysema. This also, though it is a very rare, but you can get a proptosis like this with orbitopalpebral emphysema. The coming to the laterality, it could be unilateral, like orbital cellulitis is an unilateral one. Optic nerve glioma is unilateral. Rhabdomyosarcoma, unilateral. But yes, this lymphangioma may be unilateral or bilateral also. There are typical bilateral proptosis we get in case of TED or a chloroma. This picture is showed before also, acute lymphatic leukemia, or a inflammatory disease, which is granulomatosis, or a metastatic neuroblastoma is again a bilateral condition usually. So depending on these also, we can do a diagnosis. Direction of proptosis is very important. Where if it is axial one, like we see in a case of TED, in case of optic nerve glioma, orbital cellulitis, and lymphangioma, these are usually the axial proptosis. But abaxial proptosis, if we see, then you have to think about where the lesion is situated, depending upon suppose in this case, the globe is pushed outwards. So something in the superomedially, either it is in this case, it was a mucocele, either it is a ethmoidal mucocele or a frontoethmoidal mucocele, or even an hematoma in the superior or roof of the orbit can cause this type of picture. A parasitic infection can push the globe to the opposite direction, which muscle is involved depending on that. A chloroma can push the globe to the opposite side. And metastatic lesion also, as I told, it can push the globe to the opposite side. So these are giving, all of these will give you a clue where the lesion is situated. We have to just pick up the clue. Depending on the age of onset, whether it is a congenital or it is an acquired one. If it is a congenital one, congenital more commonly is in teratoma. I don't have a picture, so I couldn't show it this. It could be a cystic eyeball, like in this one. Cystic eyeball. If you just feel it, you will see, and there is the eyeball is very small. Even in congenital dermoid, really a rhabdomyosarcoma can also be present as a congenital proptosis. Childhood acquired one is childhood proptosis, lymphangioma, chloroma. In adult acquired variety, most common is thyroid eye disease. Duration can also give you a clue which we are dealing with. Is it an acute onset? Acute means hours to week. Hours to week means either there is a trauma, there is a retrobulbar hemorrhage, or it was a chronic one like a lymphangioma. Suddenly there is a bleed and it has increased in size. That is an acute presentation. Subacute, 1 to 4 weeks. A case of orbital cellulitis. A case of parasitic infection. Chronic. In a case of a lymphangioma, you will get chronic. In case of mucocele, you will get a chronic proptosis. The progression, you have to be very careful while taking the history. How is the progression? Whether it is progressing very fast, a case of malignancy, or it is static, like a case of mucocele. Or if there is an waxing waning, like patient from lymphangioma will give you, or orbital varices, the patient will give you waxing waning of the lesion size. Origin. This is primary orbital. In case of rhabdomyosarcoma, this is a primary, it is the orbital. Or if the PNS, your nevers are very important. The nevers, like the sinuses, the cranium, these are the things. The paranasal sinuses. This is a case of malignancy in a case of ethmoidal sinus. Intracranial glioma. Glioma can occur in the optic nerve, but it can come from behind also, like from the optic nerve pathway also it can come forward. A distant metastasis, like a breast carcinoma, as I already told. So now the actual workup we have to start. This is very important. The actual workup already, if you know the background, or this is the proptosis etiology, this is the various classification of proptosis, then it will be easier to narrow down your diagnosis. Usual complaints are bulging of the eye, the pain. This is important. The pain, the onset, the side, the type, relation with the eye. This is very important. How is the pain? Is it an acute, or is stabbing, or is it dull pain? Double vision. Patient can give you a history of a double vision, that is diplopia, a binocular diplopia. If a muscle is, there is an extraocular muscle motility restriction, if a muscle is involved, myositis, or it can be a restrictive variety, or it can be neurological origin. Swelling of the eyelids presence. These are the usual chief complaint. In history, the patient, if the patient gives the history, parents give the history, then okay. Otherwise, you have to really ask for, do you have fever, rhinitis, sinusitis, nasal discharge, tooth infection, extraction of tooth, then swelling elsewhere in the body. If there is a malignancy in the breast, you can have a malignancy in the metastasis in the orbit. The history of trauma is very important. In this, I just want to share you that history of trauma is not always reliable actually. Many times a patient of proptosis comes and tell you that in 50% almost time, they will give you an history that, yes, I had a trauma in the childhood and now this proptosis has occurred. They are always ready to correlate the trauma with something happening in the eye. So be very careful about taking the history. Treatment history, what all? Take out all the history sheets, what all the written material the patient had. They don't want to expose those things in the beginning. Already the patient may have, somebody has diagnosed it, somebody has given a clue in the papers. So try to take out all the treatment history, the systemic history, family history, like diabetes, thyroid, sarcoidosis. Diabetes, if the patient is diabetic, mucormycosis, aspergillosis, all these things are more common. Patient history of thyroid, sarcoidosis. The other clues of the sarcoidosis, like uveitis, tuberculosis, it can produce a tubercular lacrimal gland involvement, dacryoadenitis, or it can produce a myositis also. Neurofibromatosis, history of neurofibromatosis, patient can give history, malignancy, other parts of the body. So these are the things you have to take very meticulous. Now the proper proptosis evaluation. In the evaluation of proptosis, we do inspection, palpation, pulsation, and auscultation. Like we learn in our surgery days, in MBBS days, surgery ward. If there is any mass, do this. So we have to do it. And before this thing, we should know what all can produce. The functional changes can be produced by this proptosis. Calor, dolor, rubor, tumor can be produced. It is inflammatory effect. Or there is some inflammatory change by the lesion, like tissue destruction, entrapment of the tissue, restriction of extraocular motility, neurosensory function can be impaired. Mass effect, whether there is a displacement can occur. Location of the mass we can find out from this. Vascular changes like obstruction to the venous return, superficial venous dilatation, pulsation, valsalva hemorrhage. So these we have to keep in mind that these are the things can occur from a mass from this. Inspection. Is there any gross asymmetry? Like many times in neurofibromatosis, there is an asymmetry. There is some thickening of that side, and there is globe displacement also. Visual acuity, as whenever we examine any case of in the eye, ophthalmic examination, we start with the visual acuity, the color vision. These are very important in a case of proptosis also. Many times in children, you may not just can do it, but whenever possible, we have to keep in mind that this is very important, because visual acuity or color vision can be impaired in a case of if the optic nerve is involved by the lesion, or if there is an compression of the optic nerve, all this can be produced. Then is there any periocular changes, that is temporal fossa fullness? That will give you a clue that it could be eosinophilic granuloma, paraneoplastic tumor, or sphenoid with meningioma. These are two tests. We commonly don't do this test, but just for the PGTs, I ask them because the examiners are very fond of this too. In the Nevzigers, you are looking at the sky just remember the birds in the sky you are looking. The examiner will stand behind and extend the neck gradually to see the superior orbital margin. And if the orbital apex, one of the orbital apex is forward, comes forward, can see you before the other one, that means that eye is proptotic. This is worm's eye view. Worm, you know, worm is, where do they live? They are in the floor or in the field. So the examiner will be below and then gradually hyperextend it and see which globe actually become more prominent, the apex of the globe. So that eye is. Some more points about inspection, like which we do in all the ophthalmic examination. Look at the eyelid. Is there any ptosis? Yes, there is a ptosis. In third nerve palsy with total ophthalmoplegia also you can have ptosis. In case of neurofibromatosis, you can have ptosis. There is ecchymosis of the eyelid along with swelling in a case of inflammatory disease. There is yellowish lesion in a case of adult onset xanthogranuloma. There is an S-shaped contour of the eyelid. S-shaped contour of the eyelid is seen in a case of typically lacrimal dacryoadenitis. Is there any lead sign that is in retraction, leg ophthalmos? All these things are seen in case of TED. Conjunctiva, if there is corkscrew vessels like this, that means some vascular changes are there. Some vessels are involved, so you are dealing with the vascular lesions, or it could be just a big size lesion in the orbit, which is causing compression over the blood vessel. That can also give rise to this type of picture. This is a case of lymphangioma, which is involved both the orbit and the conjunctiva. The chemosis, if it is a solid chemosis, that means it is a malignancy or metastasis. Look at the salmon patch colored. This is typically seen in case of lymphoma. Lymphoma again could be unilateral or bilateral lymphoma. Exposure keratopathy, a sign of in any of the proptosis you can get this exposure keratopathy. That only indicates that this proptosis occurred very fast. Lateral flare, if that is the inflammation on the blood vessels or the lateral canthus angle is prominent. This is a typical feature of thyroid eye disease. Then coming to the next one, the pupil. This is very important. RAPD present or not. Every postgraduate should know what is an RAPD and how to test it. What is the significance of this? The RAPD means there is involvement of the apex of the orbit as a superior orbital fissure, the cavernous sinus involvement. All this will give rise to RAPD. If the optic nerve is involved at the apex, as you can see in this particular, I remember this patient, it was a case of ptosis, proptosis, painful proptosis with chemosis and congestion. And the patient lost the vision when he came to us with a total ophthalmoplegia. You can see this hyperintense lesion in the MRI. This has involved most of the muscles and it is extended to the orbital apex. And there was also the disc. You have to look for whether there is any disc edema, that is any compression, or there is any folds in the choroidal folds, or in the disc sometimes you can get in case of a meningioma, you can get some vessels. The typical vessels are seen, which are known, you have to find out these collateral vessels. This is very interesting. This video actually I have borrowed from one of my colleagues. Intermittent proptosis. This is not working. Right? Intermittent proptosis. The patient usually comes to us with shrunken globe or an ophthalmos. And finally, you can land up. It's not working, sorry. The Valsalva maneuver, it will increase in a big size gradually. So that is a positional proptosis or intermittent proptosis. This is typical sign of orbital varix. Pulsation. This is a true pulsation or a transmitted pulsation. I feel this will also be, this is also not working. This could be pulsation. You can see in case of the caroticocavernous fistula or arteriovenous malformation. This was a case of arteriovenous malformation. This is a pulsatile proptosis. There may be transmitted proptosis also, cranial bony defect, meningoencephalocele, neurofibromatosis. All this will cause transmitted pulsation. I'm sorry, I could not show it. Palpation. Palpation of the temperature. That is, it was an inflammatory variety. So the palpation, the temperature will be more. The periocular tissue is inflamed in both the sides. This was a case of dacryoadenitis, bilateral dacryoadenitis. Then feel the thrill of what if it is the patient is, as I told, pulsation. You will get a thrill also in case of arteriovenous malformation or CCF. You'll get thrill. Palpation of the PNS, whether you're dealing, as I told, the navel should be given importance. That you just feel the paranasal sinuses, so that there is any deformity or that there is any increased temperature. Then insinuate the orbital margin and see whether you can feel any mass. If it is an anterior orbital mass, you can feel it. Try to feel the mass size, side temperature, surface consistency, tenderness, all this you have to find out. Resistant to retropulsion, whether you can push the globe behind, whether it is a vascular lesion, you can push it, but if it is a firm lesion, neoplastic and all, you cannot push it. Then exophthalmometry. This is for the subjective evaluation of proptosis, we do exophthalmometry to differentiate between proptosis and pseudoproptosis and to monitor the disease progression and the treatment outcome. It varies with age and sex. Not that 21 is always will be 21. It's nothing like that. In age group, like as you can see in this table, with increasing age group, gradually the exophthalmometry reading is higher. In case of male, 1 millimeter addition you have to do in each age group. Ethnicity. The African population has gotten higher proptosis measurement. What we see in proptosis measurement, the distance between the lateral orbital rim and the corneal apex. The mostly widely used is this exophthalmometer, that is Hartel's exophthalmometer. As you can see, there is an horizontal calibrated bar, and within this bar there is in both the sides there are two carriers. One carrier is, I will go back to the, within this you can see there are two rims are there, which you have to put at the lateral orbital rim. It should be a snug fill, not a very, so that the patient does not feel uncomfortable. And then you measure this through this mirror. You have to see the orbital apex. And to avoid the parallax, there are two vertical red lines. This should be made one, and then you measure this apex of the cornea in this scale in the mirror. So I think this will also not work. As one is not working, this will also not work. And this, but the drawback of this is that if there is a trauma, the lateral orbital rim is not there, then that is a problem. In that case, we have some other devices. I will come to that later. Then if there is a displacement, then how you do it? We use two scale. One is at the nasal bridge horizontally, and one is at the vertically here. So you'll get this vertical reading from the nasal bridge to the corneal apex, and the vertical one you will get from this horizontal one and up to the apex of the cornea. And if there is, as I told you, that there are other things also, if there is a trauma and lateral orbital rim is not there, we use this Nagel's variety where we don't need the lateral orbital rim actually. This is Lutz variety. This is also very simple thing. This is very handy. And if you don't have anything, then we have to take this help of this plastic ruler also. Arterial size ophthalmometer, the drawback is that this gives many times this maybe it varies from person to person. So that's why there is a thought that you have to always mention the bar reading first time, and then in the next visit also the bar reading should be keep same to avoid any error in measurement. Auscultation, you have to keep the stethoscope over this, if there is if you think that there is a pulsation, a thrill over the globe, then you can do this auscultation with the bell of the stethoscope. Some ancillary tests are there, refraction, visual field test, then tonometry, differential tonometry. Sarmat test is very important in the case of Sjogren's syndrome. Sarmat test is important. Force reduction test. These I am not going in detail. Diplopia charting is important, whether there is an extraocular muscle restriction, strabismus. Diplopia charting is a must to find out which muscles is involved and which direction the lesion is situated. Systemic workup is very important. This can give you a clue which you are dealing with. Like this type of Capella spot, that means you are dealing with a case of neurofibromatosis. If there is pigmentation in the periocular area, that I already told, if this is ear, nose, all are important. See, there is a bleeding in case of any orbital cellulitis or mucormycosis. You can get this type of nasal discharge, hemorrhagic nasal discharge. Otorrhea, I have seen many cases where this otorrhea give you a clue that you are dealing with a case of acute lymphatic leukemia. Then any history of tooth extraction. This person, the left-hand side, he came with a tooth extraction history with orbital cellulitis, and the boy in the down, this one came with a tooth abscess and orbital cellulitis. The cranial cavities, these are also important. There anything in the cranium, the fullness. At the end, I will say, if you can't remember so many points, at least remember the 7 P's of proptosis evaluation: pain, progression, past medical history, proptosis, palpation, pulsation, periorbital changes. If you remember the 7 P's, at least this will narrow down your diagnosis. Coming to the next one. At any point of time, you can do reference. This is a multidisciplinary action to be taken. ENT, you have to send the patient to ENT, to hematology, to neurology, endocrinology, oncology, radiology department. So but before sending the patient from door to door, keep in mind that what is in your mind, your history, ocular systemic examination, provisional differential diagnosis. Depending on that, you send the patient for imaging. Are you dealing with what you are dealing with? Accordingly, you ask for CT or MRI or lab investigation. We cannot send the patient from various corners that do this test, that test, not like that. We have to pinpoint the diagnosis. Like after that, you have to think your management, what you are dealing with. As I told, if the time permits, I will show you some. If you have already done a diagnosis, provisional diagnosis, you can plan a surgical excision or a biopsy. If it's a huge mass, you cannot do the total excision, or you can do an FNEC, fine needle aspiration biopsy, depending upon what you are thinking and what is your diagnosis. In some cases, you can do a conservative management or medical management. Like a case of lymphangioma, we are giving a lot of cases an injection, sclerosing agent, bleomycin, we are treating like that. Or in some cases, you can do an surgical excision also. And after that, the most important is the monitoring of the disease course. Once you get the biopsy result, your final diagnosis will depend on the HP for confirmation and the immunohistochemistry. Deepak, hello, Deepak. Hello?
Yes, ma'am.
Can I show size? Time permits,
Yes,
I'll show.
ma'am.
This is a
Yes,
case of
ma'am. Sure, you can take 5
the
minutes, ma'am.
sagittal section of this boy. This is axial proptosis. He came with an history of 6 months history. As you can see, the globe is pushed slightly down, but it is almost axial. And there is an hyper. You can see this is a lobulated mass, which is pushing the globe. So this was a case of lymphangioma or orbital venolymphatic. What we did is that we aspirated to we did blindly through this area and aspirated the fluid and injected the bleomycin, and the boy became symptom free. But this case is actually, you cannot recover this patient totally. Like in this was also a case of vascular OVLM. Partially we debulk the patient, but not the whole thing. We could not do that. Partially debulking and partially recovery was done by the injection bleomycin. So it's another boy. This was an acute presentation. Acute, as I told, acute proptosis. This is clearly you are seeing this is a hemorrhage within the cystic spaces, hemorrhage, the blood and the fluid. After giving injection intralesional Kenacort, there is almost full recovery. This patient came to us with a picture like this, the vision RAPD, pendus proptosis and movement close to face. By taking thorough history, we found that she has breast lump. And as you see in the MRI picture, there is an hyperintense lesion in both the coronal and the axial view. So this was a case of breast metastasis. Just few imaging, the important imaging, which usually, this is a case of ethmoidal mucociliary, pushing the globe sideways laterally. This is a case of granulocytic sarcoma in a case of acute myeloid leukemia in a 14-year-old child. This is a case of subperiosteal abscess from the ethmoidal sinusitis in a case of a 2-year-old child. A case of metastatic neuroblastoma. This is a CT picture showing there is triradiate lesion that is involved the orbit, the cranium, and the maxillary sinus. Metastatic neuroblastoma is usually bilateral, but in this case, it was an unilateral one. Another case of subperiosteal abscess. This is coming from the superior part. And this is, sometimes you may find out the disease only by doing an USG. So this is very handy, a parasitic cystosarcosis. A malignant lesion. This is a hyperintense lesion extending up to the orbital apex. This is a case of orbital inflammatory disease, as I told, oesogenous granulomatosis, both side lacrimal dacryoadenitis, bilateral. This is a case of meningioma, the tramtraxine. This is the typical picture of a Coca-Cola sign, which you find in a case of TED. TED for the PGs, this is very important because you should know that there is involvement of the muscle without involvement of the tendons, which is not a feature of a case of myositis. So I think I should wind up the thing. So proptosis, actually, it is like a orbit is a Pandora's box. Anything can expect for you. It sometimes you can diagnose it on the basis of what I told, but sometimes you cannot do the diagnosis without doing an HP. So this thing you have to keep in. One should not be disheartened. You have to be bold and do that. You can consult other people also that this is my diagnosis. What do you think? the thorough ocular systemic examination, prompt diagnosis and investigation, and early treatment and referral is very important in evaluation of a case of and management of a case of proptosis. These are my references. So I am thankful to my team, my PGs, my institution, and thanks for your patience hearing. Thank you all.
Thank you, ma'am, for that wonderful presentation. Anything a proptosis is there. Ma'am, I would like to ask you about your experiences in a patient with orbital tuberculosis.
Orbital
These
tuberculosis,
patients,
so
they
far,
can
yes.
just present.
Yes, I have seen 4 cases so far. One case is inferior rectus myositis that we diagnose only after doing the biopsy. That is HP only could. And another one is tuberculous dacryoadenitis, one in a child of 10 years old, and one in an adult female, which actually I misdiagnosed initially as a case of ruptured dermoid. So most of my, few of my cases already I have done publications also. And another is, I think there was a tuberculous granuloma. These are the 4 cases I remember so far.
Because these patients, they can, as you rightly said, that orbit can be Pandora's box and anything can be there. So orbital tuberculosis, usually those may just have something which would be a painless, prolonged proptosis, and because of the cold abscess,
Yes.
and there would be an irregularity in the bony margin, which would be there. So that is one thing. Do we have any other comments from the panel? Pushpa ma'am, Rita ma'am.
Yes, yes. Actually, as Madam has presented in very nice manner and extensive classification also. As we everyone know, there is only 6P. Madam has added one additional P. That
Past
is
medical
past
history.
So it is very nice because we used to teach only 6P. So now we will tell 7P. And I also one important I want to add what is the importance of Lutz scale? Because its marking is from the apex only. And often PGs are asked what is the which ophthalmometer we use in case of suppose a patient is undergone lateral orbitotomy. So often they
That's Nagel. That is Nagel's.
because superior orbit and inferior orbit. And what is the importance of base reading? Because in case of executive heart problem, you have to compare
Yes, I told that.
serial follow-up. So it is very important. So these questions are often asked.
Yes.
And it is so extensive topic and you have covered in a very nice manner. Thank you, madam.
Thank you.
Okay.
Thank you.
Another thing, ma'am, that I would like to add is about the
I'm sorry very
retropulsion
much
test.
that none of my video worked. That the reason is that I had to take another laptop because my laptop just hang just before the presentation.
That is the reason. Otherwise, it will work.
Just before the presentation,
Yes,
it crashed.
Yes, yes.
I
think,
John,
the
you were telling something.
Retropulsion test is another important test,
That I
which
told,
is
retropulsion, resistant to
that has
retropulsion.
been covered. Yes, so because that can help you to differentiate the infiltration, which is there. That was very
Solid
helpful
mass
test.
or vascular mass.
Yeah, yeah. So very helpful
Ma'am,
test.
one more question.
Nuclear and thyroid eye diseases. Yes, ma'am.
Yeah. So we have to how to write the final diagnosis in case of proptosis. It is very important.
Provisional diagnosis, we cannot say.
Final diagnosis.
Depending upon your clinical
Examination. How
workup,
to write?
you write the provisional diagnosis. And after that, you do the other things.
Pathology.
Provisional, only HP can tell you that this is your final diagnosis.
Yes.
Otherwise, we cannot. There are some in which we can say this is a case of lymphangioma. This is a case of orbital varix. That we can say. But in most of the cases I have seen that it is very difficult to do the diagnosis. But few things we have to keep in always mind that in children, we have to always ask the patient to do a CBC. That is very important. Complete blood count And if you think that is an inflammatory disease in case of young adult, you have to always do an ANCA, PIANCA, and all these things in those cases are important. But one should not ask for doing all the tests. So you, depending upon diagnosis, you ask, do the TCDC, ESR, hemoglobin, do the ANCA or PIANCA, like this. It depends which one you will ask for.
So we have to go for targeted test,
Yes.
not battery of test.
Yes.
Yeah.
So if there are not no other questions, we can move on to our next speaker. I'll quickly introduce ma'am. Yeah. So our next speaker is Dr. Rita. She's assistant professor in Department of Ophthalmology, Tirunelveli Medical College. Ma'am has done her Ma'am has done her MS from Dr. MGR University and followed by that DNB of Ophthalm as well as FAICO. She has 13 years of experience in UG and PG teaching and has a large number of publications. Ma'am will be talking about the differential diagnosis in a case of proptosis. Over to you, ma'am. Dr. Rita, ma'am. Ma'am, are you having any problem in screen sharing?
Anyway, I can help. Dr. Gunjan, can I help?
I think
Yeah,
yes,
she's
I
there.
think
She's
Dr.
there.
Rita
Yeah,
ma'am
Dr.
has
Rita is there. Yeah.
okay, she is there.
Dr. Rita, can you just put it on slide share mode? Yes, thank you. Thank you.
Yeah, please unmute, ma'am. Uh, Dr. Rita ma'am, we are not able to hear you. Please unmute yourself.
Dr. Rita, you're muted. Can you please unmute yourself? We are not able to hear you. Dr. Rita, can you please unmute yourself?
The technical team, can you please unmute the speaker if possible? Dr. Rita, ma'am, we are not able to hear you. You are muted.
Dr. Rita, can you please unmute yourself? Gunjan, can you please call Dr. Rita if possible?
Yes, I've asked to unmute the personal message also. Ma'am, please press the mic button.
IT people, can you help, ma'am? Ma'am, kindly unshare and share again.
Yes, ma'am.
Yeah,
Please
now
unmute.
it's moving.
Just see
Yeah.
if you can unmute yourself now.
Yeah.
Dr. Rita is just logging off and logging in. I think she's not able to unmute herself. So she's just logging in. Dr. Gunjan, you can take the floor.
Yeah, if we can wait for ma'am for the next 5 minutes or so, and if the technical difficulties are there, we can then move to the next speaker and we can take ma'am when she is ready.
Yes.
So we'll wait for her for
Doctor?
5 minutes.
Yeah, Dr. Rita is unmuted now. Dr. Rita?
Yeah, yes, sir. Am I
Yeah, you're
audible, sir?
unmuted now.
Yeah.
Yes,
Yeah.
yes. Now you can please start.
Yes.
Yes,
Ma'am,
sir.
you are ready.
She's there.
Okay, sir.
Okay.
Good morning to all. The same topic has already been discussed very well by Madam. So it is just repetition. I will maybe narrate in a short way. So how to approach a case of proptosis? As before entering into the disease as such, we should know a little anatomy. As Madam has already explained well, it is the orbital cavity, is the pyramidal shaped cavity. So it is like a Pandora box. So the total volume is 30 cc. So whenever there is increased volume, either because of infection or any inflammation or vascular lesions or benign tumors or malignant tumors, so there is only opening in the eye is the anterior surface. So the eye can protrude forward. So the medial wall, it is related to the ethmoid sinus and the sphenoid sinus, and inferior it is related to the maxillary sinus and superiorly frontal sinus. And so many openings are there, so that the brain is communicated with the orbit through the superior orbital fissure, inferior orbital fissure, and so that from the brain also the lesions extend into the orbit, and the medial wall, the lamina papyracea is the thinnest bone, so that even in sinusitis, the fungal mass or the infections can spread into the orbit and cause proptosis. And these are the opening superior orbital fissure and inferior orbit fissure and the orbitic foramina. And so coming to the proptosis, definition is abnormal protrusion of the eyeball secondary to space occupying lesion. So how to measure? So the extent of the globe displacement in relation to lateral orbital wall. If it is more than 21 millimeter, or that's asymmetry of 2 millimeter in between the two eyes in case of unilateral cases. So then what is exophthalmos? So it is the prominence of the eyeball secondary to thyroid eye disease, and it is usually bilateral. It is a like active phenomena because of the proliferations of the muscles and fatty tissue. So it is an active phenomena, whereas the proptosis like passive phenomena, some other mass is situated behind and pushing the eyeball forwards. Then whenever there is a diagnosis, always there is a differential diagnosis. So what is pseudoproptosis? So either the simulation of the abnormal prominence of the eye or a true asymmetry that is not the result of increased orbital contents. So either there may be one eye enlarged, globe is enlarged, or megalocornea, or irregular cornea like in keratoconus or congenital glaucoma or myopia, or either other eye is enophthalmos like prior any orbital trauma or surgery or silent sinus syndrome, or one eye may be affected with congenital deformity like a microphthalmia or exorbitism. So the other eye may be looking like proptosis, or asymmetry of the palpebral fissure height, that is ipsilateral eyelid retraction or facial nerve paralysis or contralateral ptosis. So in such a cases, you should there's a possibility of pseudoproptosis. So coming to the classification. So anatomical classification, depending upon the laterality, etiologically, and onset and variability. So coming to the anatomical classification, so whatever lesions, so intraconal lesion, there are specific spaces, that is the central or the intraconal area space, and the extraconal space or the peripheral space, and subperiosteal space or the subtenon space. There are 4 spaces are there. So whenever there is a lesions in the intraconal, there is either it may be a cavernous hemangioma or optic nerve glioma or meningioma or AV malformations, or some muscular disorders like muscles affected in thyroid or ophthalmopathy or orbital pseudotumor or cysticercosis or lymphoproliferative disorder. So this causes increased intraorbital volume behind the globe and it pushes the globe forward. So it produces axial type of proptosis. And eccentric proptosis means it is pushed down, either upwards or downwards or laterally or down and in or down and out. So infralateral proptosis. So mass is in the supranasal quadrant. So either it may be arising from the frontal area, frontal sinus, frontal tumors, or frontal mucosal, or frontal abscess, or any osteoma or rhabdomyosarcoma. Then lateral proptosis. So it may be lesions arising from the ethmoidal tumors, ethmoidal sinus. So either it may be ethmoidal tumors or mucosal or lacrimal sac tumors or nasopharyngeal tumors that pushing the globe laterally. Then superior proptosis. So the inferiorly, it is related to the maxillary sinus. So any maxillary sinus carcinoma, adenocarcinoma, or squamous cell carcinoma. So it is infiltrating into the orbit and pushing the globe up superiorly. So superior proptosis. Or any inframedial proptosis. So the structure in the supralateral aspect is the lacrimal gland. So whenever there is a lacrimal gland tumor or dermoid cyst or sphenoid wing hemangioma or meningioma or rhabdomyosarcoma, this pushes the globe medially and down and in proptosis. So these are few examples for eccentric proptosis. This first person is an adenocarcinoma of the maxillary sinus extending into the nose and through the medial aspect, it enters into the eye causing and upward and lateral proptosis. And here it is second one is the frontal lobe tumors pushing the globe downwards. So this is some ethmoid mucosal pushing the globe down and out. And this is a nasopharyngeal carcinoma presented with proptosis and the eyeball is pushed down and out. So etiology classification is a congenital and infection, inflammation, vascular, and trauma. So congenital means mostly this dermoid cyst or neurofibroma or craniostenosis. Infection means mostly it is orbital cellulitis or abscess or unilateral cases. If it is bilateral, you think of cavernous sinus thrombosis. And next is inflammation. So either it may be due to thyroid-related disorder or non-specific orbital inflammation. Vascular causes like capillary hemangioma, cavernous hemangioma, orbital varices, and carotid cavernous fistula. Tumors like glioma meningioma, lacrimal gland tumors, surrounding sinus tumors, and rhabdomyosarcoma. So depending upon the laterality, so unilateral proptosis mostly arising ocular causes. You think of ocular causes. If it is a bilateral, mostly systemic, like thyroid or leukemia or lymphoma. So unilateral causes like orbital hemorrhage, so hemorrhage or dermoid cyst, tumors of the orbital sinus, or metastasis, orbital cellulitis, or capillary or cavernous hemangioma. So bilateral means it may be a cranio-stenosis or cavernous sinus thrombosis or thyroid disorder, or orbital tumors like leukemia and lymphoma. Basic on the acute onset means mostly it may be orbital hemorrhage like retrobulbar hemorrhage or orbital emphysema. Intermittent means think of orbital varices, lymphangioma or hemangioma. If it is a pulsatile tumor, maybe it is caroticocavernous fistula or transmitted pulsations from bony defect like in meningocele, absence of sphenoid in neurofibroma, or in basing of the age of onset. In case of children, it may be due to capillary hemangioma or veno-lymphatic malformations, optic nerve glioma, rhabdomyosarcoma, leukemia, metastatic neuroblastoma, teratoma, or vascular lesions. In adult, you think of cavernous hemangioma, mucosal, lacrimal gland tumors, lymphoid tumors, meningiomas, and metastasis from breast, lung, and GAT. So Madam had told 7 P's. So in addition to that, pain, progression, pulsation, proptosis, palpation, and periorbital changes. So in addition is past medical history. So pain. So pain is present means mostly it is infection or inflammation. Progression, depending upon progression. So rapid means it is hemorrhage. So immediately it will come. Moderate means it is infections. Slow means mostly it is neoplasm. So then pulsation. So either it's the continuous pulsations or transmitted pulsations. Pulsations means it is caroticocavernous fistula. Transmitted pulsations mean any meningocele or neurofibroma. Proptosis, you can measure this mild or moderate or severe proptosis. And palpation, you can come to whether it is cystic or solid or irregular or bony destruction or any dermoid cyst, some bony indentation you can see, and periorbital changes like discoloration and like that. So when the case of proptosis is coming, how to approach? A proper history is very essential. So history of onset, whether this presence since childhood or later ages, and whether any trauma history is there or any pain is there, like that. History is very essential. Then ocular examination and proptosis as ocular examination and proptosis measurements. Then in relative blood investigations and imaging and histopathological examination and management. So history, age of onset and duration and progression. So progression, it is static or very slow progression, or usually very slow progression in malignancy. And pain, with whether it is present or absent. Pain is present means mostly it is infection or inflammation. Sometimes in necrosis in the tumor in long-standing cases also presented with pain. Then postural variation, that is in case of orbital varices. So in lying down posture, lying down position, it disappears, and then Valsalva manner, it increases. So diurnal variation also in trauma, and ENT symptoms like epistaxis or autoria. So these are the signs of sometimes presented in esophageal carcinoma, or in bloody discharge from the nose in case of black eschar in case of mucormycosis, and signs of increased ICT in case of brain tumors, and it's spreading into the orbit, and systemic like fever, loss of appetite in case of other vascular lesions or leukemia or lymphoma. Then coming to the visual acuity, so it's reduced in exposure keratopathy and optic nerve compression. So in optic nerve, it is so up to 8 millimeter of proptosis, and optic nerve is not affected. If it is more than that, so the optic nerve is affected and it causes optic nerve compression and optic neuropathy, and presented with optic atrophy and loss of vision in case of non-standing tumors. Or if it is more than 8 millimeter in thyroid-related optopathy, it reduces the vision in case of because of the exposure keratopathy. Sometimes occurred hyperopia, like changes occurs in refraction. Sometimes mass is pushing behind the globe, and pushing the lobe, so it causes acute hyperopia. So these are the changes you'll expect in visual acuity. And lids, so swelling, edema, discoloration, retraction in case of thyroid related ophthalmopathy, and S-shaped deformity in neurofibroma or lacrimal gland tumors or dacryoadenitis, and lag of thalamus. Then conjunctiva, you can see the chemosis and Salmon patch in case of lymphoma, and dilated vessels you can see in thyroid vessels, thyroid disease, and cornea you can see the exposure characteristics, and iris leash nodules will be seen in neurofibroma, pupil RAPD may be seen. So in optic nerve glioma and meningioma, so the only sign will be defective vision. You can see the RAPD. So in the fundus, you can see the papilledema or choroidal folds and optic atrophy. So extraocular movements restriction. So you have to check the extraocular movements also and do the diplopia charting also. It's the case of rhabdomyosarcoma with ethmoid and sphenoid sinus metastasis and orbital apex syndrome. So IOP, it is elevated in thyroid ophthalmopathy and AV fistula. Braille's test, it is the differential tonometry. So you have to measure the intraocular pressure in the primary gaze and ask them to look for the muscle, the up gaze. So in case of restricted muscle palsy, the IOP will be elevated in more than 8 millimeters of mercury. So it is, so proptosis measurements, as Madam had already well explained. So Lewis exophthalmometer, Heckel's exophthalmometer, and if it is in the eccentric proptosis, you can measure it with two scale procedures. Horizontally, you place the scale at the nasal bridge, and vertically at the pupillary area. So that, so from midline, how many millimeters it is pushed, and how many millimeters it is pushed downwards. So this is a simple method. You can measure the eccentric proptosis and the worm's eye view. So from the patient's seen from below. So which until the head is tilted back. So which eye is looking seen first. So that is the proptotic eye, and you can see the fullness in the temporal area. So this is it is present in sphenoid wing meningioma. And you have to look for the occipital bone also, some in oxycephaly or craniostenosis, premature closure of the frontal suture. So the shallow orbit, even the normal eyeball will look like a proptotic eye. So this is a Pfeiffer syndrome. It's a premature closure. It's represented looking like bilateral proptosis. And then coming to the palpation, so the swelling, you have to assess the size of the swelling, extent, and consistency, whether it's soft or hard or bony hard, or so then transillumination. So cystic and benign will be transilluminant, and fixity to the underlying bone. So so that you can come to the conclusion. So this case, one of the cases is presented with dacryocystitis with abscess formation 2 times outside INC done. And when you take the on palpation, it is stony hard because this lady has presented sinus carcinoma, and it is with the skin necrosis and abscess formation she presented. Then we referred the case to the tumor board and went for some excentration of the eyeball, and the patient is doing well now. Then you can do palpate the orbital rim in case of orbital floor fracture or irregularity or in resistance to retropulsion. So it indicates malignant tumors and compressibility. So either it may be vascular or lymphatic lesions, and reducibility. So any soft tissues will lead to reducibility, and finger insinuation. So you have to insinuate the fingers in all around the 4 walls. So whether it is able to insinuate the fingers or not, and palpable thrill. So it indicates carotid cavernous fistula, and look for any increase in Valsalva maneuver or carotid or jugular compression. So it is suggestive of orbital varices. So pulsations, so carotid cavernous fistula, fistula, the vascular lesions, and transmitted pulsations means meningocele or absent sphenoid in neurofibroma. So, and look for the signs of thyroid orbitopathy. So, Dahl-Rimble sign, so STAD, look, Joffrey sign, Stellwag sign, and Mobius sign, defective convergence, and Van Graffy sign, defective down lag on down gaze. And Afsiger sign is seen from the behind the head, ask the patient to tilt the head. So, the prominency of the eye is you can see easily. So most common cause of bilateral proptosis in adult is think of thyroid ophthalmopathy. Most common muscle involved is inferior rectus, as in connected as more connective tissue and macrophages are seen in the inferior rectus. So it is a case of thyroid ophthalmopathy with extra muscle restriction with the superior and inferior scleral show lid retraction. And auscultation bruit is felt in case of carotidocavernous fistula. So coming to the investigation, so all the cases it is must to do the complete blood count. So most of the cases of leukemia and lymphoma, the count will be elevated, or any infections. So recent infections, the neutrophils will be elevated. Long-standing cases, lymphocytes will be elevated, and MANTO and ESR. And next is importantly should do the thyroid function test. Then look for overt cyst in case of neurocystic sarcosis, and taken culture and sensitivity in case of orbital cellulitis. So radiological X-ray. So lateral view, some foreign body locations you can easily locate it, and water view, blow fracture can be identified, and Reese view optic new foramen. So widening of the foramen and irregularity of the foramen will be seen in glioma and optic meningioma, neurofibroma, and paranasal sinuses you should take. Some mass may be arising from the paranasal sinus and encroaching into the orbital cavity causing proptosis. Ultrasound is needed in case of orbital benign tumors and parasitic cysts and foreign bodies, and ocular inflammations like thyroid eye disease and myositis. And CT is advisable in case of orbital masses if undiagnosed disc edema, unexplained ophthalmoplegia, or paranasal sinus affecting the orbit, or nasofrontal tumors affecting the orbit. CT will be identified. And Hillard-Trolley's classification measurement is proptosis by using a mid-orbital axial scan. A straight line is drawn between the anterior margins of the zygomatic bone, and the vertical line is drawn at the level of the lens. So we can measure the amount of proptosis by conformations we can do in this. Then in MRI scan, some orbital apex compression or intracranial lesions or soft tissue lesions can be highlighted. So this thyroid eye disease with the Coca-Cola bottle sign. It is here that typically the muscles are enlarged and sparing the tendons. Whereas in case of orbital pseudotumor or orbital idiopathic orbital inflammatory disease, the muscles, tendons, both are involved. And then, so based, come to the conclusion, based on the cause, thyroid eye disease, so treatment. So thyroid eye disease is the commonest cause of bilateral proptosis. Even in unilateral asymmetric proptosis also, first think of thyroid eye disease. So if it is an active disease, so better to observe the disease. And so if it is progression, then you give pulse steroids to reduce the active inflammation. Once it is settled and fibrotic stage, then you go for surgical corrections. So if it is active disease, to prevent the optic neuropathy, you can give intravenous steroids, and when it becomes stable, you can do the decompression and strabismus surgery. So the principle of orbital decompression is broad and fraud. That is, the expanding orbital volume is reduced by bone reduction orbital decompression, and reducing the orbital soft tissues by fat reduction orbital decompression. Then coming to the treatment of CCF, so embolization involving placing small platinum coils where the abnormal connection is there, that's the treatment of choice. Then treatment of IOID, that systemic steroids, treatment of infections, antibiotics and antifungals, and tumor management, excision, and chemotherapy and radiotherapy. So this is a bilateral raccoon eyes in children, no history of trauma. So you should rule out neuroblastoma with the secondaries in the orbit. So this is how we can evaluate a case of proptosis and management. Thank you.
Thank you, Rita ma'am, for the excellent talk.
Thank you, sir.
Yes.
Thank you, sir.
And I think the best part of your talk is the way you shown each and everything, how to go for the signs, symptoms, and the things. Dr. Gunjan, you want to say anything or ask any question?
Can I say something?
Yes, ma'am. Yes, please.
Yes. Actually, I was confused because her topic is differential diagnosis of a case of proptosis. Then how can it is changed? Number two, her presentation should we go for management? Suppose a question comes for PG clearance. If a question comes, how to approach a case of proptosis, then I don't think we have to write the evaluation and investigation in DD, not management, as far I know. So can you clear the moderator and or chairperson? Should we go for management or not?
See,
Management, see,
it may
slightly
vary.
hinted in last 3-4 slides, if you ma'am watch, she mentioned about the management. But what happens, usually the management part is little bit less covered, but almost she covered it, although it's not in so much detail.
Because we have to clear about the how to evaluate, it is only evaluation part. Then how to approach, mane evaluation plus DD. If then how to manage, then management is investigation and treatment. So we should clear about this thing. As for I know. So you
Okay.
can put more.
When there is a long question, then the PGs
Yes.
who are watching will take your notes, means how
Notes.
to write or
Right.
what to write in the theory.
Yeah.
If
Actually,
these words are given,
yeah.
evaluate or approach like that.
Yeah. So they should
Thank you, ma'am.
clear
Good,
understanding.
good suggestion, ma'am. Good suggestion. Dr. Gunjan, can we invite the next
So I
speaker,
think,
Dr. Tomar?
yes, I think proptosis has been covered in great details in all the aspects. Now we can move to our next speaker. I'll quickly introduce Sir. Now this topic. So our last speaker today is Dr. Vijay Pratap Tomar, sir. He's a professor in Regional Institute of Ophthalmology, Sitapur. He has done his diploma in ophthalmology from RIOS and his fellowship in uvea and medical retina from Shankar Nethralaya, Chennai. Then he joined as a senior consultant at Sitapur Hospital from 2013. He has been a resource teacher for uveitis in AIOS, ARC, PG teaching courses and is a zonal representative of Uveitis Society of India. So we'll be talking about decoding posterior uveitis. Over to you, sir.
One thing more, Dr. Gunjan, Dr. Tomar is a very good singer and very popular in PGs.
Thank you so much.
That has to be added in the CV also.
Thank you so much for your kind words, Deepak and Gunjan. Whether my slides are visible?
Yes.
Yes.
So thank you so much, Dr. Harbans Lal sir, the President AIOS, and Dr. Santosh Honawar sir, Secretary AIOS, and the entire team of AIOS who has given me this opportunity to interact with the brightest mind of ophthalmology, that is our beloved students. So today we are going to discuss a topic which is a little bit tricky, but I am going to make it very simple. So in our day-to-day clinical practice, we see the patients of posterior uveitis and we have many differential diagnoses in our mind. Then how to reach the final diagnosis? So there are certain questions which should be in our mind, that whether what we are seeing is retinitis, or is it choroiditis, or is it retinochoroiditis, or neuroretinitis, or retinal vasculitis. Whether the disease entity is having some element of anterior segmental inflammation, or the patient is having vitritis. Whether the certain systemic clinical features are there or not, and whether all these clinical features are fitting into some particular specific entity. If the disease is having a recurrence, whether it was treated previously, and if yes, how the disease was responding to the treatment. So, meticulous clinical evaluation along with the detailed history, followed by the tailored lab investigation, helps us in reaching the diagnosis and the management of that particular disease. Now, making it more simple, if you are seeing a case of posterior uveitis with vasculitis, think of Behçet's TB and sarcoid. If it is choroiditis or retinitis, always rule out TB, viral diseases, Behçet's, Toxoplasma and Toxocara. If it is associated with hypopion, rule out infective etiology apart from Behçet's. If it is associated with exudative retinal detachment, rule out VKH and SO. And if there are multiple white dots, think of white dot syndromes. Now coming one by one. So if you are having a young patient who is having a hypopian uveitis with an element of vitritis along with vasculitis, which is affecting both arteries and veins, think of Behçet's disease. The first scripture of Behçet's disease was deciphered by Hippocrates of Kos in the 5th century before the birth of Christ, and later on it was the Greek ophthalmologist Adamantidis and the dermatologist from Turkey, Behçet, who actually presented the detailed manifestations of this disease. Since the disease is more common in the younger age group, it affects 25 to 35-year age group of patients. And the disease is more common in males than the females. Behçet's disease is also known as the Silk Route disease because the disease is more prevalent in the countries of Eastern Pacific Rim of Mediterranean Sea and the Eastern Asian countries. The maximum prevalence of this disease is seen in Turkey, Iran, and Japan. And because of that, Behçet's Research Committee of Japan has proposed the diagnostic criteria, which has 4 major criteria and 5 minor criteria to diagnose the disease. And depending on that, they have further classified this disease into a complete one, incomplete one, suspect, and possible. But the worldwide, it is the International Study Group for Behçet's disease classification, which is used to diagnose the disease. And in both the classification, the recurrent oral aphthous ulcers are very, very important to diagnose the case. The students should learn both the classification by the heart so that they can write the answer as well as can diagnose the case in their clinics. So the recurrent oral aphthous ulcers with at least 3 episodes in a year, along with any 2 of the following, that is recurrent genital ulcer, ocular manifestations of Behçet's, dermatological manifestations along with post-surgery test, they should diagnose the disease. Here, the systemic evaluation is very important in the Behçet's disease. The patient usually presents with the painful aphthous ulcers. Remember that the lesions in the reactive arthritis, which was previously known as Retter's disease, in Retter's, the ulcers are painless. In the Behçet's, the lesions are painful. They comes in the crop, they can present over the lip, they can present over the tongue, they can present over the oral mucosa, they can be seen at uvula or at the palate or the posterior pharynx. The lesions are creamy whitish, ranging from 0.3 mm to 15 mm. They comes in the crop, goes off within 7 to 10 days without leaving any scar. The typical pattern of lesions are also seen over the genitals. In the males, they are seen over the glans or over in the scrotal area, and in the females, they are seen over the vulval and vaginal mucosa. In the females, always try to rule out herpetic lesions because they mimic closely with the Behçet's lesions. But sometimes remember that in females, in Behçet's lesions can be painless. Apart from the oral ulcers, dermatological manifestations are also noted in the patients of Behçet's, and they can be in the form of erythema nodosum pustules, which are seen over the shin of the tibia, face, nape of the neck, or over the buttocks. Apart from these lesions, they can be in the form of acneiform eruptions, and the phenomena of dermographism has been seen in 1/3 to half of these patients of the Behçet's. The Behçet's presents as a non-granulomatous anterior uveitis with mobile hypopion, but with the frequent use of topical steroids, now this hypopion is seen only in 20% of the cases. So if a patient who is not having hypopion but other manifestations of Behçet's, please don't rule out that, oh, hypopion is not there, this is not a case of Behçet's. No, it's not like that. And always do a gonio, because sometimes this hypopene is so small that you can miss that. So gonioscopy is a must in all the uveitic patients. And if NVIs are present, it is always a bad prognostic indicator. Isolated vitritis is highly uncommon in the patients of BASIX, and obliterative necrotizing retinovasculitis is a hallmark of BASIX, which is affecting both arteries and veins. There's the dilatation of veins as well as capillary along with the engorgement. FFA is always advisable to do in all these patients, not only to diagnose, but also for the follow-up, so that you can ascertain that whether the disease is responding to the treatment or not. On FFA, you will see there is a dilatation and occlusion of the retinal capillaries with massive leakage, giving it a fern-like appearance. Always look for the choroidal non-perfusion areas. Remember that in BASIX, capillary involvement is massive. Apart from that, in the follow-ups, you should look for the collateral formation as well as for the NVEs, NVDs, and disc staining. The BASIX can have varied manifestations. They can present as papillitis or neuroretinitis. Sometimes papilledema can be there, which can be a manifestation of neurobasics, and recurrent episodes of BASIX can lead to optic atrophy. Vascular occlusion in the form of CRVO, BRVO, CRAO, or CRVO can be there. And particularly if a young patient who is presenting with vascular occlusion, always try to rule out collagen tissue disorders or BASIX. In the repeated episodes, you can see the sheathing of the vessels along with the RPE alterations, and in the recurrent episodes, you can also see peripheral choroidal scarring. So before diagnosing BASIX, always try to rule out the other causes of vasculitis, and HLA-B51 testing should be done. But it is not always true for all the cases. Suppose if a patient is presenting only with the mucocutaneous lesion, go for the HLA-B12. If they are having arthritic manifestations, always do HLA-B27. And sometimes what happens that ocular manifestations precedes the systemic manifestations, and in these cases, HLA-B5 is typically seen. The mainstay of the treatment is systemic steroids along with the immunomodulatory drugs. So now if a patient presenting with posterior uveitis, predominantly with retinitis and vasculitis, think of ARN, particularly when there is few or multiple discrete areas of peripheral retinitis, which is spreading circumferentially. Remember the word circumferential spread in the absence of antiviral treatment, with the element of anterior chamber reaction or vitritis, with occlusive retinal vasculitis predominantly affecting arterioles. Remember, in the BASIX, it is the capillaries, and in the ARN, it is the arterioles which are predominantly affected. And there is the typical Swiss cheese appearance of the fundus in the patients of ARN. These patients can also present with raised IOP or hypotony. Severe vitritis or vitreous exudates can be seen. The retinal necrosis is so much fulminant in these patients that retina gives a sieve-like appearance, and because of that, multiple atrophic retinal tears can be there, which can lead to the retinal detachment. Remember, ARN is bilateral. So if your patient is presenting the disease in one eye, always have an eye on the other eye, because this disease can present, if you are not treating them correctly, the disease can affect the other eye. Always have the history of exanthematous fever before the presentation, and always look for the scars for the chickenpox and herpes zoster vesicles. The diagnosis is mainly clinical, but it can be confirmed by the means of PCR analysis of the aqueous as well as the vitreal samples for the viral genome. And when it is admixed with Goldman-Whitmer coefficient, the sensitivity and specificity to diagnose the disease is very high. Retinal biopsies are indicated only in the cases of diagnostic dilemma. It was Kirisawa who scriptured the first memoir of ARN in 1971, and that's why the disease is also known as Kirisawa uveitis. The disease is more commonly seen in immunocompetent patient, and the most common cause of ARN is varicella zoster virus, followed by herpes simplex, CMV, and EBV. Systemic antiviral therapy is the cornerstone of the management of the ARN, and the role of steroid and prophylactic laser barrage is always controversial. Surgeries is required if retinal detachment is there, but the results are not very promising. If you are seeing a patient who is having several multifocal, deep, dense retinal necrotic lesions, predominantly involving the posterior pole, always think of PORN, particularly if it is an immunocompromised patient, maybe because of HIV, or patient is on immunomodulator drugs for any organ transplant. The disease is more commonly seen when the CD4 count is less than 50. And the fundus gives a typical cracked mud appearance. The prognosis is really very poor because of the retinal as well as the optic atrophy, despite treating these patients with 2 antiviral drugs. CMV retinitis, as we all know, is seen in immunocompromised patients, particularly when the CD4 count again is less than 50. There are 3 distinct patterns. The first pattern is the classical or fulminant hemorrhagic necrotizing retinitis, where massive hemorrhage and exudation is seen around the vascular arcades. Then there is the granulent indolent form. Here, the granular lesions are seen in the periphery and the disease is not spreading aggressively. The third one is again a very aggressive form of vasculitis, which mimics frosted branch vein angiitis, and the mainstay of the treatment is antiretroviral therapy along with the intravitreal ganciclovir or foscarnet, or followed by valganciclovir orally. So if a patient is presenting with posterior uveitis with choroiditis and vitritis, what should we think? If a patient is having a choroidal or retinal necrotic area, particularly seen over the posterior pole, later on developing dense vitritis, giving a typical headlight in the fog appearance, think of toxoplasma. Remember that toxoplasma usually present as a unifocal lesion. If it is multifocal, think of a different diagnosis, because it is highly uncommon to get toxoplasma multifocal presentation in an immunocompetent patient. Toxoplasma retinochoroiditis is the most common infectious etiology of posterior uveitis in immunocompetent patients, and there are 2 modes of presentation. It can be a congenital transmission by the means of placental route, or it can be acquired by the ingestion of contaminated food or water, and there should be a history of contact with pets, particularly the cats and dogs. For the congenital toxoplasmosis, always look for the Sabin's tetrad. Means there can be a hydrocephalus or microcephaly. There should be mental retardation, intracranial calcification, and the presence of typical cartwheel lesion of toxoplasma retinochoroiditis over the posterior pole. 90% of these cases are asymptomatic. The disease is transmitted in 15 to 20% of the cases in the first trimester and in 60% of the cases in the third trimester. But remember, as early the disease is transmitted to the kid, the chances of severe manifestations are high. They can be diagnosed antenatally by the means of PCR and ELISA and indirect fluorescent absorption test for amniotic fluid, and in the postnatal cases we can do IgM antibodies or double sandwich ELISA that using anti-P30 IgA antibodies and indirect fluorescent antibody test. CT scan brain shows intracranial calcification, and USG abdomen shows hepatosplenomegaly in these kids. The acquired toxoplasma patients, the diagnosis is mainly clinical and ELISA is non-confirmatory until unless there is rise in the IgM antibody. PCR and Goldman-Whitmer coefficient is very much helpful. If Goldman-Whitmer coefficient is more than 4, it is always diagnostic of toxoplasma retinochoroiditis. Sabin-Feldman dye test is the gold standard, but we nowadays don't do that because of the high infectivity, and anti-toxoplasma treatment with the help of one sulfur drug and one non-sulfur drug along with oral steroids is the mainstay of the treatment. Think of toxocara if a kid is presenting with a peripheral granuloma with the history of contact with puppies and with the history of pica. The toxocara can present with granuloma in the peripheral retina and vitreous. The second most common presentation is posterior pole granuloma, followed by chronic endophthalmitis-like picture, optic nerve involvement, and the anterior segment involvement is least commonly seen. The diagnosis is done by the means of toxocara excretory secretory antigen IgE antibodies, and the sensitivity again increases Bill Goldman-Whitmer coefficient. Since toxocara is a differential diagnosis of leukocoria and the toxocara is commonly seen in children, always do a ultrasound and CT scan to rule out retinoblastoma. Initially start systemic steroid followed by anti-helminthic drugs, particularly the mebendazole or albendazole, helps us in treating these kids. Whenever that posterior uveitis is presenting with exudative RD, rule out VKH, sympathetic ophthalmia, and multifocal choroiditis with panuveitis syndrome. Always look that whether the disease is unilateral or bilateral, is there any history of trauma is present or not, any choroiditis lesion is there or not, or the disease is coming again and again as soon as we are tapering off or we are stopping the steroids. So suspect VKH if you are seeing bilateral granulomatous uveitis along with disc edema with multiple subretinal fluid pockets in both the eyes. Always look for the systemic manifestation in the form of vitiligo, poliosis, loss of hairs, meningismus, dysaceusis, vertigo, and tinnitus. FFA is very much helpful in diagnosing all these cases. Here you are seeing that a little amount of disc edema with subretinal fluid pocket is there, and as soon as you do FFA, you can see early pinpoint leakage giving a starry sky appearance. And in the later phase, you will see that there is the pooling of the dye along with the staining of the disc. Apart from this, we can also do ultrasound B scan, which shows retinochoroidal thickness apart from the exudative retinal detachment, which can be evaluated by the means of shifting fluid phenomena. On OCT, we can see multiple neurosensory detachment. So Wong-Koyanagi-Harada disease is a multi-system autoimmune disorder which principally affects pigmented tissues. Why? Because there is the formation of T cells which are directed against melanin. So wherever melanin is present, whether that is the skin, whether that is the retinal pigmentary epithelium of the retina, whether that is the organ of corti in the ear, they causes destruction there. So that's why we get multiple system involvement. There are 4 stages: prodromal stage, acute uveitic stage, convulsant stage, and chronic recurrent stage. And in the convulsant stage, we see sunset glow fundus, and there may be the presence of Dallen-Fuchs nodules. Students should learn by heart the revised diagnostic criteria of VKH. And remember, there shouldn't be any history of trauma or any history of surgery, and all the lab investigations should be done to rule out other entities. There shouldn't be any lab investigation positive. And the mainstay of the treatment here is systemic steroid followed by the immunosuppressive agents. Whenever there is a history of trauma, along with the bilateral manifestations as seen in the VKH, think of sympathetic ophthalmitis. The affected eye is known as exciting eye, and the other eye is known as the sympathizing eye. The earliest symptoms are mild visual disturbance, and there is the near vision compromise because of the change in the accommodation. And in the affected eye, significant visual loss is noted. The time of injury is really very important to all these patients. 80% of the patient usually presents within the 3 months of the trauma, and 90% of the patient presents within the 1 year. And the most crucial period is between the 4th to the 8th week. But there is literature which suggests that the disease can present as early as on the 5th day, and there are 1 case report which showed that SO developed after 66 years. In my clinical practice, I have seen a patient of SO who presented after 12 years of initial injury. There are various theories regarding the SO. the management is really very important in the era of immunomodulatory drugs. If you cannot salvage the eye, enucleate that. But if you can salvage, it should be dealt very aggressively by the means of systemic steroids and immunosuppressive agents. So how will you differentiate SO versus VKH? If no history of trauma, bilateral presentation, this is VKH. If history of trauma, this is sympathetic ophthalmitis. Systemic manifestations are more commonly seen in VKH than in sympathetic ophthalmitis. Dallen-Fuchs nodules can be seen in VKH. They are seen in 1/3 to half of the patients of sympathetic ophthalmitis. But there are certain masqueraders. Posterior scleritis can mimic like VKH or SO. If a patient is having pain, particularly on the eye movement, you should think of scleritis. Because anteriorly, you are not seeing any congestion. On fundus evaluation, you will see the disc edema, subretinal fluid pockets, along with the internal limiting membrane folds, and some element of vitritis may be there. Do ultrasound B scan to see the T sign, but this T sign is not seen in all the patients. FFA is again very much helpful, and its presentation is similar to the SO and VKH. The second most common masquerader is a multifocal central serous chorioretinopathy, but any sign of inflammation or pain is not seen in these patients. And FFA helps us in diagnosing multifocal CSCR from SO, VKH, and posterior scleritis, because we see the typical ink blot and smokestack pattern in CSR patients. Now coming to the systemic diseases. Always rule out TB when you see a patient of posterior uveitis, because we all are living in a country where TB is endemic. And TB is having protein manifestations. The choroidal tubercles can be of size of 3 millimeter to 15 millimeters. They can be 1/3 disc diameter size up to half disc diameter size. They can present as a solitary tuberculoma of 2 disc diameter to 10 disc diameter size with exudative retinal detachment, and these tubercles or tuberculoma can be seen with hemorrhages or without hemorrhages, with exudates or without exudates. TB can also cause vasculitis, and it is sometimes very difficult to say that this vasculitis is because of the tuberculosis itself or this is a hypersensitivity reaction to the tuberculous antigen. Always do a Mantoux and quantiferon TB gold test, that is IGRA, in all these patients, and do a chest X-ray and CT scan. If you can do PCR from aqueous or vitreous, particularly pointing out the MPB64 gene, this is really going to help us. But ELISA and PCR of serum is not useful in endemic countries like ours. Sarcoid is a very close mimicker of TB. It can present as vasculitis, but the sarcoid vasculitis is a little different. Here you will see that there are the skip areas of vasculitis, and the typical presence is known as Takis indibogi. You will see the candle wax drippings, and it affects veins more commonly like TB. They can present as choroidal granulomas, and these granulomas are seen usually in the periphery, and they are of the size of the pinhead. They can present as a solitary granuloma. Sarcoid can present as a neuroretinitis. So if you are seeing a patient of neuroretinitis, always rule out sarcoid. And believe me that sarcoid is not very uncommon in India. This is a common disease nowadays in India. For the systemic manifestation, look for the erythema nodosum and lupus pernio. Lupus pernio are purple placoid lesions seen over the shin of the tibia. Now, how to diagnose? Remember that Mantoux is negative in the patients of sarcoid because of the cutaneous energy. But suppose if you are seeing a patient who is Mantoux negative, please don't rule out TB even now, because Mantoux can be negative in immunocompromised patients. So what to do next? we will have to do a X-ray chest and HRCT. And we should look for the bilateral hilar lymphadenopathy. On CT scan, look for the beaded vessels. Here you can see that beaded vessels are there on CT. Serum ACE titers should be evaluated very carefully. They can be seen raised in other granulomatous diseases like leprosy, syphilis, and TB. Apart from that, the higher levels can be seen in chronic smokers as well as in children. Bronchoalveolar lavage should be done to see the CD4-CD8 ratio, and histopathology actually clinches the diagnosis in all these cases. Syphilis is a great mimicker. It is also known as French pox. The granulomas closely mimics the granulomas of TB and sarcoid. Syphilis can present as retinal necrotic areas in the periphery, but these are not rapidly spreading, closely mimicking as ARN. So it has varied manifestations. Syphilis can cause vasculitis. So always do RP or VDRL and TPHA to confirm the diagnosis. Remember that VDRL is negative in latent syphilis and it becomes negative after treating the syphilis. But once the TPHA is positive, it is positive for the lifelong. So always do both the test, VDRL as well as TPHA, if you are suspecting syphilis. And treat the patients of syphilis as a patients of neurosyphilis with the help of IV penicillin G. But remember that whenever you are planning to start penicillin G, always give a bolus injection of IV methylprednisolone to prevent the Zarek-Herxheimer reaction because of the killing of these treponemal. Now the last entity, white dot syndromes, and it is really very difficult for me to elaborate all the white dot syndromes. White dot syndromes is a group of ocular disorders which is characterized by the presence of whitish lesions in the choroid, RPE, and or neurosensory retina. And there is really a very long list starting from APM-PPE to birdshot chorioretinopathy. Now I'm going to discuss the few important ones which we see in our day-to-day clinical practice. Acute posterior multifocal placoid pigmentary epitheliopathy, shortly named as APMPP. As the name suggests, there are multiple round, circumscribed, flat, yellowish white placoid lesions seen over the posterior pole, extending up to the equator. The disease is having minimum vitritis and it is usually bilateral. Initially, patient can present unilaterally, but the other eye is going to be affected in some time. And usually seen in the younger patients, and there is no sexual predilection. If you will do FFA, you will see numerous lesions than you are seeing clinically, and there is early hypofluorescence followed by the late hyperfluorescence. Then the multiple evanescent white dot syndromes. These are multiple small, tiny, discrete lesions seen over the posterior pole, around the macula, as well as around the disc. And by the means of slit-lamp biomicroscopy, you can diagnose them more correctly than seeing them on indirect ophthalmoscope. The disease is commonly seen in females than males. Remember this thing. And uniform macular granularity is the pathognomonic of mutes. If you will do FFA, here you will see a wreath-like configuration. And again, the lesions are more in number than the clinically they are seen. Usually the lesions of choroid are early hypo, late hyper when you will do FFA, but this is the multiple evanescent white dot syndrome, punctate inner choroidopathy, Krill's disease. Here you are getting early hyperfluorescence and late hyperfluorescence also. The next common presentation of white dot that we see is serpiginous choroiditis. The disease usually affects the age group of 30 to 60 years. Previously, it was known as geographical helicoid peripapillary chorioretinopathy. If you see this fundus picture carefully, the lesions are seen adjacent to the disc involving the posterior bone. They are irregular, grayish-white, creamish subretinal axons. The disease is bilateral, chronic, recurring, and progressive in nature. And the active lesions are seen at the periphery. You can see that as the disease is progressing, there is central scarring. Fundus autofluorescence is a very good tool to see how the disease is responding to the treatment. As soon as the disease started resolving, the hyperautofluorescence becomes hypoautofluorescence. Here you can see, this is the active lesion. Here, just correlate. This is active lesion. This is hyperauto. But here the lesions are healed. There is no autofluorescence is noted here. So it's a very good diagnostic tool to see the improvement. Multifocal choroiditis and panuveitis, this is usually seen in young adults. And again, here the females are more affected than the males. Mild to moderate non-granulomatous anterior uveitis is seen, and the lesions are seen close to the disc and they are spreading towards the equator. A distinct propensity for the peripapillary and nasal side of the mid-periphery is very, very common in this disease. But before branding a fundus multifocal choroiditis, always rule out TB, syphilis, presumed ocular histoplasmosis, DUSN, and viral retinitis apart from the other white dot syndrome entities. And the treatment is steroids along with the immunosuppressive agents. Punctate inner choroidoretinopathy is mainly seen in young myopic females. And the common presenting symptoms are blurred vision, photopsia, scotomas, and metamorphosis. And it is again a bilateral disease. But there is no anterior uveitis and vitritis as compared to the multifocal choroiditis, because there is a hypothesis that PIC and multifocal choroiditis, they are the two spectrum of the similar disease process. Absence of CME or disc eczema as opposed to multifocal choroiditis or mutes is seen in PIC. But the most common complication of PIC is CNV. As I have told earlier, that if you will do FFA, you will get hyperfluorescence in the early arterial phase with staining in the AVs. Here you can see there is a CNV, the most common complication of PIC. So remember one thing, that whenever you are seeing a patient of posterior uveitis, a detailed clinical history followed by a meticulous ophthalmic as well as systemic evaluation admixed with tailor-led lab investigation is going to help you diagnose the disease. And here are my acknowledgements. My Shat Naman to our beloved Chief Dr. S.S. Badrinath, who has changed the pattern and practice of ophthalmology in India. And my sincere thanks to my mentor, Dr. Jyotirmay Vishwas, Dr. Sudha Ganesh Madam, Dr. Amla, Dr. Sudarshan, and Dr. Pratim Datta Majumdar, who taught me the nitty-gritty of uveitis. And I am also very much thankful to my student and a good friend, Dr. Shivangi Kapoor, who helped in managing my slides. Thank you so much, AIOS, once again. Thank you.
Thank you, sir, for that informative lecture on posterior uveitis. You have, in short, covered everything. All the aspects have been touched. And masquerade syndromes, I think they are the most tricky part in dealing with posterior uveitis, because sometimes lymphoma can also present like posterior uveitis.
Yeah, true. Actually, whenever that lymphoma is there, that lymphoma actually mimics sometimes as intermediate uveitis, and sometimes that creamy whitish lesions are there over the retina. So that's why the role of retinal biopsy as well as the choroidal biopsy actually comes. And I think that if you are suspecting that you are dealing with a lymphoma, I think it is better to send the patient to higher centers, because if you are planning for a vitreous biopsy or a retinal biopsy, you will have to fix the sample within half an hour. Otherwise, those lymphoma cells are going to die.
Yes, and one more tricky part there is lymphoma can initially respond to steroids also.
Yeah,
There are
initially
very high
response.
chances to misdiagnose it.
Yeah, Gunjan. And apart from that steroids, because that steroids comes in the CHOP regime, and
Yes.
and we also give methotrexate. So initially, when you are putting your patients on methotrexate who are not responding to the steroids, initially they respond, but later on they don't respond. So you will have to go for the intravitreal methotrexate for all these lymphomas. And whenever you are suspecting it is a lymphoma, I think that you should always do a MRI brain, because in certain subset of patients, it is actually the ocular manifestation of lymphoma that comes first.
Do you have any comments from the expert panel? Deepak sir, would you like to add something?
Dr. Gunjan, Dr. Tomar is, I know him since we both are consultant at same time at SCH. He is so much perfect, and I've seen him preparing slide one by one with each and every points, and he beautifully covered almost all the things as far as my best knowledge is concerned in the uvea. And rest, if there is any question or anything, we can have his talk or contact number we can show to rest of the residents who they can contact him anytime. He's very friendly and helpful for them.
Students are always welcome. They can call me, they can mail me.
Thank you, sir.
So, I think we can conclude this session. Dr. Gunjan, you can say thanks to each and everyone. Thanks to
Yes.
Pushpa ma'am, Chanda ma'am, Rita ma'am, Dr. Tomar, and Dr. Gunjan. And thanks to our president, Harbans Lal sir, who has planned such a beautiful thing for the PGs. And again, we are thankful to Santosh Anawar sir, our honorary secretary of AIOS, for giving us opportunity to moderate this session and do the class.
We wish you the best night.
Namaskar.
Good afternoon.
Namaskar.
Thank you, everyone. Thank you.
Thank you.
Thank you
Bye.
so much.
Vistara
Thank you.
Thank you. Bye. Bye, sir. Bye, sir.
Yes,
Bye, bye,
really,
bye.
really a nice